Welcome to the 12th edition of Kerala Society of Ophthalmic Surgeons Scientific Committee CME series. In fact, this is the first online CME program that we are having after Dr. Sai Kumar has taken over as the president of Kerala Society of Ophthalmic Surgeons. So we have decided to do this program a bit differently. What we have done is to have a program in which the PGs and the very young ophthalmologists who have not been really well trained in cataract surgery will get an idea about what training facilities are available in different institutions across India. So what I've asked all these institutions to help me out with is to come out with a half an hour sort of a presentation in which they'll describe their long-term, short-term fellowships. If they have very ultra short-term fellowships, even if they have a paid fellowship when the trainees pay and do it, all this, and also what is the stipend that is given to the fellows during their fellowship? What are their responsibilities? Do they have to go for camps? If they have to go for camps, how many camps they have to go? When would these kids get to do their first surgery on a human eye? When would SICS be started? When would FACO be started? So I've asked them to cover everything. So by the end of this program, we are doing it on 2 days. All these kids can compare between the facilities available in different institutions and take a decision as to where to go. So with this introduction, let me welcome, first of all, my teacher, my guru, Dr. Lalit Verma, who has kindly consented to inaugurate this program. He has just traveled back from the Haryana Ophthalmic Society annual conference. Dr. Sai Kumar, need not welcome him, but I have to do that. So Dr. Sai Kumar is the president of KSOS. Sir, welcome you to this program. Dr. Deepak Misra, Dr. Deepak Misra is secretary of International Society of Small and Cataract Surgeons and convener of the surgical skill transfer course of AIOS. So he'll be giving a small talk immediately after the inauguration. Dr. Asim, whom everyone looks up to. I mean, yesterday also I was talking to Dr. Prasad, and everyone has such high, great regard for him, respect for him, and all the consultants from across the different institutions who have kindly consented to present in this CME. I welcome all of you, and now I request Dr. Sai Kumar to take over as the presiding officer for this inaugural session.
Thank you, Srini, for your brief, kind words of introduction. Lalit sir and all the other senior surgeons in this group. What Srini has planned today is a very unique, I think probably the first of its kind program, which if I'm not wrong, where you have various training strategies being showcased for all the young ophthalmologists to look into and decide where to do a fellowship, what all to expect from a fellowship, and things like that. So I'm sure this is going to be very, very useful for all the young ophthalmologists. And like what the KSOS has been doing for the past 1 year and continuing is that we are associating one of our district ophthalmic clubs also along with it. So today we are associating with the Alappuzha Ophthalmic Society. The members of the society, Dr. Manoj, Dr. C.K. Matthew, Dr. Anil Dutt, Dr. Lima, they're all present in this meeting. So welcome to all of you, and all the presenters from. I think we are having 6 hospitals today and 6 tomorrow.
Today. Yeah.
So I'm sure this is going to be very, very useful for the young ophthalmologists. And who else other than Lalit sir to inaugurate this function officially as president of the AIOS and a teacher of ophthalmologists for many generations. So Lalit sir, please speak a few words and officially inaugurate this program. And I also welcome all the other panelists and all the other people in Zoom who have joined in Zoom to attend this program. Lalit sir.
Thank you, Dr. Sai and Dr. Sreeni, for this wonderful opportunity. And you see, for last couple of years, KSOS has been very, very active in this pursuit of academic, education all across. In fact, I've been quoting KSOS everywhere that, Sreeni, the chairman of the scientific committee, Gopal, the general secretary, Sai Kumar as president, they have been doing wonderful job. And today, another feather in the cap, once Sai has joined as a president, is about this cataract perfection techniques and training. A wonderful opportunity, and really proud of KSOS. If you allow me, Sreeni, I'll just share a couple of slides which I had for this.
Please, sir. Please, sir.
Yeah.
Please, sir.
So you see what I hope they're visible.
Yes, sir.
Yes, sir. Yes, sir.
Yeah. So you see, these wet labs have been very, very close to my heart. The reason is that, you see, I always believed, even at AIOS, theoretical knowledge can be gained in the classroom through Google and through so many things happening. But I always believe that a surgeon, because all of us are targeting towards budding ophthalmic surgeons, is that before he touches a human eye, he should always have his feel on some experimental eye before he touches. Because when we were residents, we never had such opportunities. You see, my first cataract surgery was just given to me, and I touched that human eye, and there was a vitreous loss in the first case itself. Nobody actually taught. So in any case, whenever I got this opportunity, when I was chairman of the scientific committee, I, with the help of, Deepak, Misra, Sudhanshu, so many other people, Tejas Shah was also there in the beginning. We started this wet labs. Initially, whenever you start new thing, you are always ridiculed by your seniors. What nonsense you are doing, you're wasting so much of area. You could have accumulated 2-3 crores of rupees from here and whatever. So I thought, believe me, Sai, this happened. And you see, I thought there is a responsibility. And I, as chairman of the scientific committee, had this responsibility to teach. And we started this wet lab. And these practical courses, believe me, they were a hit from the day one. I remember way back, we started from Delhi conference. Now we are into 81st conference. We started in 73rd conference. And initially they were, free, but since the enthusiasm grew, we started charging also, because aim was not to earn money. Aim was to make these people serious that they will attend these wet lab courses, because it takes a huge amount of effort. So we started in Jaipur. You see, we started with, I discussed with Deepak and a lot of other people also. So we divided into 2-3 types. One is diagnostic, where you increase the diagnostic ability of the people. One was surgical, where, you teach people on things, SICS or maybe phaco or injections or some things. And studying the response, we, keep improving. I just run through because there's not much text here. There are a couple of slides of Jaipur. He is the, Rajasthan minister. He inaugurated that. And then, we also started giving presentation certificates to the attendees, as well as, Mallika was the member of scientific committee at that time. And so this was, you see, this was the response at Jaipur conference. We had a total of 662 delegates, who registered for 131 courses. So one delegate may register for more than one course also. So then Coimbatore also, we had similar courses. You see a couple of glimpses of that Coimbatore event. You see the enthusiasm. Just wanted to show this, the enthusiasm to learn was there. And obviously we had a lot of members who pitched in, but the main thing was played by Deepak and Sudhanshu. And Deepak was the main convener of this program. And we had diagnostic also. And Malika was always there with us. Frankly speaking, we should, tell something about Sambasiva Rao, because he was the first person, in fact, before I started, he had already started doing, wet lab courses, but those were, just started, not very well attended, but we took it to a different level. This was the couple of courses which became very, very popular. And these were the conveners of, technology skill transfer courses. This couple of, this Coimbatore event, again, we had phenomenal response. And in Indore also, we had so much of, the stations. We prepare stations at each lab. Now, Sai, this has become a routine, not only at AIOC, but I see it virtually. I've just come back from Hisar, Haryana. There was a wet lab station, which I inaugurated there also. So every conference, people have started doing these wet lab courses. The aim is singular of all. We have this experimental eyes where, people, there's a mentor here, like you see Kasturi here, have a short interaction, and then they teach on these goat eyes. On these goat eyes, or there are a lot of silicon eyes also available. And there's a one-to-one interaction. See, we prepare this, various stations, and each of these course, which I had shown as a station, and a lot of areas there. And you see, this is diagnostic, this thing being explained to and these people can ask, questions there and clarify all their doubts, like these 12 courses in TSTC. So again, phenomenal response, 1,500 courses, we had registered. Gurugram, again, we had so much of response. So aim of all these wet lab courses and is primarily to make the budding ophthalmologist have a feel and clarify all their doubts from practical point of view. These are the certificates, we distribute to these people, which are signed. So popularity grew. You see, this is just showing from Jaipur to Coimbatore to Indore, how these, courses, grew, and they had a steady, 841 people registering and for these courses. Same is true for diagnostic as well technology. Not only this, we had a huge fund collection also. You see, around 9-10 lakhs collected. This dip is primarily because of COVID, which was there. And even in this, recently concluded Patna conference, we had another, this wet lab thing, which we labeled as RTI, which was a round table interactive course. This is again a part of wet lab only, where one person, you see the mentor here explaining. So this opportunity is these delegates get at this big events is phenomenal. This was SSTC area in Patna, where we had these courses, this surgical skill transfer courses. Again, this was prepared by Deepak Misra. We had this. So what I was wanting to, the reason I showed all these slides was to, at a national level, this has become popular, and I'm very, very happy. I'm very proud to inaugurate this unique initiative by Sai, Srini, and Gopal and the entire team, where members or young budding will have an opportunity. Like Srini was saying, they will know. Like I just read through your flyer also. So like 6 today and 8 tomorrow, 14 institutions are participating. Not an easy deal, not a small deal. So I know, Srini, what kind of effort you would have, and the background you must have made to contact all these institutions, and they will tell what courses they offer. And then we, leave it to the people that these are the institutions which are offering these courses, and this is the infrastructure available, so they can choose. So I salute the KSOS who have begun this a unique kind of program, and it will be of benefit to all the budding ophthalmologists. What budding, even people who want to learn, it's not only for juniors, If anybody who wants to learn that particular thing which he does not know, he can always go and attend. So thank you, Sai, and thank you, Srini, for this opportunity given to me, and all the best for this unique program. Thanks a lot.
Thank you, sir.
Thank you, sir. Dr. Sai,
I want Gopal to speak a few words.
Yeah.
Because, he has been, along with you, the backbone of this entire program since the last 1 year. I have joined only recently. So Gopal, just in a few sentences, please share your experiences of this, online courses that we have been doing. Me and Gopal in the Cochin Ophthalmic Club, sort of started a Zoom revolution for about 2 years.
It was a huge revolution.
Gopal continued with it into KSOS.
And I'm telling you, Gopal, the whole nation is watching this. The whole nation knows about this. And wherever we go, we keep quoting the, phenomenal job which Gopal, Srini, Sai, everybody is at KSOS is doing this. Yes, Gopal.
Thank you very much, sir. It is just that I have been educated by my own teacher, Dr. Lalit, on taking the opportunities with both hands. And when COVID came, we took the opportunity with both hands to see how we can enter into the living rooms of almost all the ophthalmologists. And now with KSOS, actually we had spearheaded one other program called Eye Literacy for All, which means not just for ophthalmologists, but for optometrists, paramedics, and also for the general public. So bringing ophthalmology into a mainstream discussion, creating an advocacy for ophthalmology among the politics as well as the public was the aim, and we are trying hard to reach that game. And here is a program which is very, very unique. Today itself, I was in the Noel Monies, and a lot of young children were coming to talk to me to say that, sir, today we will not be able to attend because we are here. But I said, yes, it will be YouTube forever. It is not that you are going to miss it, because they would want to see the educational institutions for cataract surgery and how each place is different, and they can actually evaluate. So this 2-day program is not just a program to educate them, but actually this will be seen again and again each year by thousands of young ophthalmologists who want to take up a fellowship and cataract surgery and IOL fellowship or phaco surgery. So I salute to the ideas that Srini gives us. It's a big team effort. It's not just Srini, me, Dr. Sai, or anything like that. Dr. Arup was instrumental in starting a lot of things and putting this into the website. And it's a huge, big team behind us who supports us for that. Thank you, Dr. Lalit, sir, for showcasing us everywhere. Thank you very much, sir, from the bottom of my heart. And I wish this program all the very best. Thank you.
Dr. Sai, can we, now that, Sai, you're muted, Sai.
Do we have someone from Alleppey to just put in a word before we actually...
Dr. Manoj is here.
Manoj?
Yes, sir.
Please, your thoughts, comments before we commence the actual program.
Yes, sir. You're audible.
Manoj is a senior professor in ophthalmology in the Government Medical College in Alappuzha.
This is an extremely unusual and useful topic that is being discussed today. Extremely useful as well for the budding ophthalmologists. So happy to be a part of this program. Actually, because of another CME which is happening in Kochi right now, some of our members are yet to join. They are, I think, on the way to Alleppey. I don't know if they are, if they can, link in, join the link while they are traveling. But some of them said they are trying to. Anyway, I hope this will benefit them all. And thanks so much, Srini, Sai, and the entire team of KSOS for associating us with this CME program. Thanks to all the speakers who are participating, and looking forward to the session ahead. Thanks a lot.
Sai?
Without...
Yeah, Sai, if we can conclude this session fast, like
inaugural function is we can conclude the session and get along with the...
So effectively, Dr. Manoj has given the word of thanks. Dr. Dalia, who is supposed to be their president, but she could not, as Dr. Manoj said, she's traveling. So without much delay, we'll go to the. I'll just we'll see. This is what I planned as a primer for the whole program. Since we have Dr. Lalit Verma, whose baby is the skill training courses of AIOS is there with us. He has already explained what happened, how he started SSTC and all. And Dr. Deepak, who's a very energetic ophthalmologist, keen in academics, and an associate professor in RIO, BHU Varanasi, chairman of ARC UPSOS, is a founder of PG Examination Forum, and is a national convener for SSCC. See, who else to actually speak on the setting up wet labs? So I thought we'll have that as a primer to the sessions by different institutions. Dr. Deepak, if you can actually share, if there is any difficulty, Ankit will. Can you please try again?
Sure, sir. Sure.
Yeah.
My slides are moving, sir.
Yeah, very good.
Well,
go to slideshow and you can start.
Thank you, sir. Thank you. First of all, I would like to thank Kerala Ophthalmic Society for giving me this opportunity to speak on something which is very close to my heart, and under the guidance of Lalit sir and other seniors, I have working on it since last 7 years. There is no financial interest. First of all, why wet lab is important? A wet lab courses.
Deepak, can you make it full screen?
Sir, it's full screen from my side.
Then there is there will be an issue. Let's not try waste time trying to fix it. What you have to do now is go to the site, specifically pick the next slide. No, it might be difficult. Do this screen sharing same way. It will be seen like that, and you can point to the next slide. Now what we are seeing. Okay, now it is fine. Yeah.
No, it's fine.
Yeah, it's fine. Good.
Okay. So why it is important? Most important is that this wet lab courses helps them to attain the skill, but not only the skill. Most important thing is they can do practice or whatever the things is important in a risk-free environment. That is the most important thing which we want to know or learn from the wet lab courses, that you have to attain the skill, develop coordination, but the environment is risk-free. Means there is no harm to your patient and there is no mental trauma to the budding ophthalmologist too. For the setting of wet labs, we divided it into the 4 segments. First one is the space. What is the space required if anyone wish to set up a wet lab? What are the requirements? Requirements are divided again into 2 parts, consumables and the equipments. What will be the curriculum? Ideally, a wet lab should have a curriculum based on which residents should go for that, and how much cost is involved in setting these wet labs. First of all, space. Space is something which we can say that space is anywhere in the department which ideally located in the main building. Why main building? It is very much important that residents should get time for doing wet labs in an off time, means after your OPD or after your OT. So if it is in the main building or the place where the access for resident is available at least for 24 hours, if not 24 hours, then at least 4 or 5 hours after their routine work, then it will work for them and they can do it practically. And another thing which is important in the space is any size room which have at least accommodate 2 people. 2 people are there, one for the trainee and one for the trainer. This is the ideal wet lab settings you have seen in the graph. any room of 10 by 10 size or 10 by 10 feet is sufficient enough, in which we have at least one table, which you have seen here, there something to fix the eye. If you have any old microscope or the table held microscope is enough, and one monitor if it is visible to connect and other can see what you are doing. If not available, then even the single eyepiece or the viewer system attached to the microscope works well. This is the same thing which you have seen we have created in the AIOS. This picture is taken from the AIOS wet lab courses. Here you have seen the same settings. And if space is less, means there is no space that one can sit side by side, then space can be adjusted that the trainer and the trainees will be one by one and they can see what we are doing. Some places are somewhere, if space is not enough to create all types of wet labs in a different, then you can have in an open environment for any conferences or anywhere where you have just create a space, a 3 meter space is 3 feet space is enough between two tables so that they can easily learn with each other. Now coming to the consumables depend upon two things. One is the type and nature of surgery. Which type of surgery or nature of surgery we are going to provide in the wet lab, and another is the number of persons or trainees. If only 4 or 6 residents is there in your institute or place, you can adjust or make them so that they have only 3 to 4 people. And the nature of surgery, if you are going for the cataract or VR training, which type of training you are going, then you have to bring the consumables of that. And common things which I can suggest, which must be at least, this is must to have list in which you have at least sutures, whatever the sutures are there. Gloves is important, where I am saying that because most of the goat eye is having prone for the infection, hepatitis A and C infections. So at least a one glove should be there, for the disposable gloves should be there. Blades, goat eye, and if patient resident is not doing something on the goat eye, then at least banana or the apple or another thing which is available to practice them there. These are the different material in which we can practice the suturing. That is the traditional technique. Most of us, if you have seen, there is a suturing not done here, here and here. For the on the thermocol, you can even practice on the banana. These are the goat eyes, and this is something a backside which we have used it in a phaco. For the equipment and instrument, I am saying that at least one microscope with side scope is available. That is good enough. If not available, then any old monitor available in the department or the camera screen which can be connected with that TV screen, that is good. If it is a cataract wet lab for the phaco emulsification, then one phaco machine is important. And most important is the dustbins for the biomedical hazards. Look, this is an important thing which usually most of the wet labs initially missed out, and they are throwing these goat's eye here and there, and next day no one will going to open that door because of the smell and the garbage, everything. So it is important that a dustbin, which looks to be a very simple thing or easy, but it makes your wet lab much more comfortable for the trainer and the trainees both. And the list of equipments and instrument, again, we all know, I'm not going in detail of it because all this depends upon the which type of surgery we are going to train. Another important requirements I have going to tell you is one is the thermocol ice box. If thermocol ice box is available, then keep the goat eyes in the thermocol ice box so that it stains with normal tissue viability for some times. And for most of the time where the phaco training is going on, they have to make this goat size slightly harder by microwaving them for a short period of time. So if these two things is available, it will be a good wet lab. Eyeball fixating devices, these are available by many companies. We are in AIOS, we have used it. You have seen a screw so that you can easily fix this wax eye on this maneuver. And even we have a stand. These steel stands are available in which you slightly fix the goat eye, and here people are practicing for the intravitreal injections. This is for the VR surgery for anti-vitrectomy. Here you have to fix it, go tie with simply 2 pins are here. Most likely it's not visible, but after these 2 pins, we have just micropore and tape them with the help of microscope. Now the wet lab devices which are coming are good because they are previous ones all are horizontally placed on the table, but this one is a vertical one. Here you have seen that this is a vertical one device placed, and here anyone can do applanation or gonio on this. It easily fix it on your slit lamp, and at the height of the prism, you can go directly and touch with the goat cornea and practice even the diagnostic skills like applanation and other. A wet lab curriculum. Yes, wet lab curriculum is important because of 2 things. One is it makes a target for the resident that yes, I am on this scale, I am on this scale. And what we usually suggest is wet lab program should be on the rotation. Means what third year is practicing in a wet lab, their courses will be slightly more different as compared to the first year. So this is a wet lab training program we have designed or find out how much we can do it. So at least for the first year, a 10-0 suturing on the thermocol or goat size importance. Why I am placing or insisting on the suturing? Because suturing is a one step which helps a lot. It gives us the hand-eye coordination, it provides important depth perception and tissue handling. All the things which we expect from our first year is that if we are having doing something, making side port or making tunnel, at least he know how to suture it. For the second year onwards, then you have to give them whatever the second year is going. Important step is the making corneal and scleral wounds. That is the important thing. If they can practice capsulorhexis, this will be again a good thing. And loading and unloading of AIOS and another things can be practiced in a second years. And third year is for something for the cataract. It is basically designed for the cataract. And for the cataract, third year, the practice is on the learning their phaco machine. How much should be the bottle height, what vacuum, how we preempt aspiration flow and phaco. And after that, we can give them, once they are well versed and having the knowledge of foot pedal hold and combination of them, understand their phaco machine, you can give the wax side to them to do they practice the phaco. Simulator is also available nowadays, but the only advantage is, disadvantage is they are costly. And advantage here you have seen this resident is practicing on the wet lab on the simulator. And here if you see, here is a green and light dots coming. These dots give you an idea for the resident and everyone. Means if it is in a green zone, then his incision is good. If it is not, then it comes to under the red zone. So if any institute can, we have well funded, they can have simulators too. It gives more real experiences. Here you have seen these markers, with whatever she has done, Rexis, it is good or not, and what is the parameter. It's more objectively assessed. The cost of wet labs always depend upon the equipments, but I am saying and giving important for them that even for a minimum cost, we can have a wet lab. And there are few tips to cut the cost cutting, which we use. Anyone can use their older phaco machines for the wet lab. And if possible, then if microscope is not available, then nowadays table mount microscopes are coming at low cost. That
One second.
don't kindly mute anyone.
Most
kindly mute. After that, we have some allow the resident to practice.
Somebody is speaking it with on the mute account. Okay, Deepak, continue.
Okay, sir. If these microscopes are not available or anything not available, then even at +10D glasses or the something available commercially in a market, hardly costing for 250 or 500 rupees. They have just like a +10 glasses and do the practice. And for the suture and everything, nowadays non-sterile sutures are also coming. Most of the even RO labs are providing wet lab sutures. Even the expired or the remaining sutures you can use always we used from long time for the practicing in the wet lab. And this is our article under the guidance of Lalit Verma sir. We published in the IGO that essentials of setting wet labs. All of the much more details are available here for that. But my take home message is do a proper planning. Just create a small space and give comfort. It doesn't require a lot of fund. So fund is not an issue. Most of the time when I go for the MCI inspection or MC inspection, people said that funds are very less, so we cannot have a proper wet lab. But I am telling you that proper wet lab doesn't require a lot of funds. Only you have to manage your waste products or everything in a proper way, and you can utilize them with minimum fund. But the important thing is the knowledge and will. Will is very much important. If as a faculty, as an institute, you wish to provide a wet lab area for your resident, it is, I am sure that you can do. If there is no will, it's different. So knowledge and will is the important key message to set up a wet lab, which I feel so. And with this, I would like to thank you all. My phone number and mobile number is there. If anyone wish to set up wet lab anywhere in their institute, or even resident can set up in their hostel, they can contact me anytime. I'm ready to help you. With these words, thank you all.
Thank you, Dr. Deepak. It was a really wonderful presentation. I'm sure that it would be seen again and again by many of the people who want to start wet labs in their training institutions. And as you said, the PGs, if it is not getting done in their institutions, PGs can get it done in their hostels. If anybody needs any clarification from Dr. Deepak, we have 2-3 minutes. If not, Dr. Deepak has shared his phone number, or you can contact me. I'll give you Dr. Deepak's phone number. Thanks a lot. It was a great presentation, Deepak. Thank you. So without delay, we'll move to the first hospital to be presenting in this CME. And which other hospital other than Aravind hospitals, which actually started the quality revolution in India in ophthalmology. The low cost, high quality training. There's just my daughter is doing 5-year management in integrated management course. She's showing some program EQM or something. So in which I mean, she was making a presentation. I was just she was showing me it. So it is like, see, when the volumes increase and the requirements and the need to do more numbers, to need to cater to more clients increase, there is a possibility that it might affect the quality. So how do you maintain the quality with such humongous volumes? Aravind hospitals have shown us, and this quality has spread all across India. It's not just limited to South India. See, everyone. See, Dr. Asim still is an example. He was the pet of Dr. Venkateswamy, and you can see what he has done in his part of the world after getting training in Aravind hospitals. Now, today we have the two of the youngest generation ophthalmologists from Aravind, Dr. Shankar. You all know Dr. Adiyar, how great a man is. He follows Dr. Adiyar, Dr. R. Sankarananthan. He's a senior consultant in Cataract and AIOS services. in Aravind Eye Hospital, Madurai. And he'll be joined by Dr. Senthil Prasad, consultant cataract and IOL services, Aravind Eye Hospital, Madurai. I just have to talk about Dr. Adi Ravindran with Aravind presentation here. See, when I was the General Secretary 2 terms back of KSOS, we actually wanted to start low vision care in Kerala under KSOS, because I knew that the low vision treatment programs in Kerala is not that great. So I wanted to start it for KSOS. I was thinking of, see, I had my super support of my president, Dr. Shashikumar, and Dr. Radha Ramanan at that time. So I had contacted many major institutions to get the optometrists from Kerala training and all. It didn't happen. And just one call to RDR sir, he said, Srini, we'll do it. We'll do everything. And we have three low vision care centers in Kerala running with the collaboration of KSOS. So, Dr. Shankar, can you start your presentation?
Yes, sir. Thank you for involving us in this presentation, sir. As you said, we are the youngest in the lot, and I'm very happy to be part of this very elder team with Asim sir and other most senior sir. So we will start our presentation, sir.
Yeah, please.
Sir, are my slides visible, sir?
Yes, visible.
Okay. Thank you, sir. Good evening, everyone. I would like to thank the Kerala Ophthalmic Society for this wonderful opportunity, and Dr. Shivakumar sir from Aravind Tirunelveli, who introduced me and gave me the opportunity to get involved in this esteemed program. We are just coming back from finishing our workshop on simulated training of in SACS for around 40 residents under postgrad residents in medical colleges around the Tamil Nadu area. So cataract surgery in general, if you see, we have performed around 6 lakh surgeries around the ICAS system in the year 2021 to 2022, of which 1 lakh were performed in Madurai alone. This number might be staggering, but the most interesting part here is around 70,000 surgeries were performed by residents and senior fellows. Now, how was this possible? This is possible only because we have a structured training program which helps us achieve this goal. This structured training involves the daily routines. Like there are lots of structured classes which will be coming down in my future in my down slides. The goal of my presentation today will cover all the aspects included in the program, from what is we offer as a in the wet lab, and then what is short-term fellowship, what are the merits and demerits of it, and what is long-term fellowship, the duration of the fellowship, the other details that are involved, like leave durations, the salaries, the number of surgeries they get at the end of the course. All those things will be as much as detailedly revealed by me. So this is the course that is offered in our wet labs. The surgery for the small incision and phacoemulsification is for 1 month. And recently we have the simulator from Help Me See group, which we involve, which we have for about 10 days. And also we have a 1 week program for our internal Aravind residents and fellows. In Aravind, the program started in the year 1993. With the beginning, we had ECC, SICS, and then phaco. This was actually the way it has been started is the way we have been trained also. We need to do 100 ECCs before we go to SICS, where we need to perform close to 1,000 surgeries as residents, and then we have to move on to phaco. The reason behind this program was initially started was what we heard from our seniors and Dr. V was that, and Dr. Venkateswamy sir was that, in order to eradicate needless blindness, we need to train as much of ophthalmologists so that the Arvind's mission of eliminating needless blindness is achieved. So these centers are the ones which have cataract surgical training. Now at present, we still have this is also available in Salem, Chennai, and Tirupati also. The object, like I said, the key objectives would be to train people in SICS, where it is easy for us to convert ECC surgeons to SICS once they have the knowledge of performing good tunnel and having applied 5 to 6 sutures in their tunnel. They are also able to perform the tunneling very well. PHECO is also given to them based on their skill levels in how they perform in SICS also. The simulation part, this is a new thing that has joined our wet lab kit. It's really helpful now. My colleague will detailedly present regarding that. This is our structured program in our wet lab. This is the structure which is we follow for both PHECO and SICS. There will be intense detailed lectures regarding every step of SICS, which will also be followed by observation in the OT, where the trainees need to observe senior surgeons for the first 5 days of the month. After which, under supervision, based on the clinical lecture that was step lecture which was taken on the previous day, that surgeon will do the particular step. After which, there will be a post-op rounds in which the surgeon gets to see not only his surgery, but also the other colleague's surgery and senior surgery also. This will help them understand the importance of each and every step and its results as in the immediate post-op. And coming back to the wet lab, these surgeons get a detailed video review of their surgery that they have performed on that particular day. And then the next step would be taken, after which they have various options to practice on, like the goat side, cadaver eye, and now the simulator. We also have an extensive theoretical library with our own SICS book written by Dr. G. Nachar Madam. And then we have multiple videos which are in detailedly explained by senior consultants on every step. Even for PHECO also, it is the same schedule. So now coming to, now they have performed their surgeries. Now how do we assess them? For every stepwise surgery that has been performed, for every day, we have an Oscar scoring sheet. Based on the Oscar scoring sheet, their skill levels will be assessed. And especially the post-op review is not done by the trainer himself. The senior most consultants in the department, like our head of the department, myself and Senthil, and 2 other senior medical officers, on turn basis, we go and evaluate their post-ops, teach them whatever we can teach in the ward so that they can understand the importance of the steps. This log book is maintained in detail so that the case numbers, so that they can review the cases, they can follow it up in case there is any complication. So the simulation came into existence in Madurai in the year 2021, around March, after which it will be discussed by my colleague afterwards. So now we have 3 different groups in our institution. We train them in 3 different groups. Like once the 1 month training course that begins for the residents after their 5th month into the undergrad, into the post-graduation course. The fellows, long-term fellows who join us, they will start their surgical training after 3 months. So even after this training, there are few residents or fellows who have to be retrained because of their increased complication rates. So based on this, we took up 6 PGs in the last 1 year. We trained them extensively. We monitored them on a day-to-day basis in the OT as well as in the wet lab. Now we have drastically reduced their complication rate from 5 to 1.3. During this period of observation, they had performed 120 cases between them, which are close to negligible complications. The second group of doctors that we train is people who do consistently very good, but they're not able to do high volume, which is really required by our institution. So we train them in a way, we give our hints, we share our thought process, and that helps them increase their volume significantly. Now, surgeons who are doing very good volume, but they're not able to manage their complications, or they're not helpful, or they're not able to help their colleagues. Again, that's the third group that we take up a different class, where we involve them in complication management like anterior vitrectomy, CTR placements, and hooks and capsular hook placement. Regarding short-term fellowship, the course is for 1 month, both for SICS and FACO. The charges might vary from what I presented, but it is a recent upgrade, recent released price. For SICS, it is 40,000, and for FACO emulsification, it is 70,000. And we give them 25 surgeries opportunity in SICS, and in FACO, we give them 20 hands-on surgeries. This is a very structured area where the surgeons who come to us need to perform 3 temporal surgeries, temporal SICS surgeries before they start their FACO training pack. Here, every case of them is recorded and reviewed in the evening. They have an extensive opportunity to practice on the simulator, the growth side, and the rexis practice. This is something that we do in Aravind, where we make sure the doctors practice their rexis in an IOL box. On the back of the box, we place a 1 rupee coin, we make an imprint, and over that they practice the rexis. This extensive discussion is also very important. As you know, books may not give all the details that is needed. The students, when at the end of the day, somewhere around 5 or 6 in the evening, the senior consultants sit with their videos and also bring their own videos for discussion. So this helps them understand the importance of each and every step that they do. In long-term fellowship, which is for 2 years, it is like they have to contact Uma's sister in Lyco through our official website, where all the details regarding the application have been shared in the website. The stipend is for the first year and second year are mentioned as such. And in SICS and in FACO, the numbers are 1,500 for SICS, and it is actually a much bigger number only most of our fellows do. Now, currently we have 18 fellows in our department, and 7 of them are above 1,300. So they have performed 1,300 SICS. Now, these surgeries are evaluated extensively by head of the department and AIOS also, because we have the CAT2 software which makes sure all the doctors are monitored based on their complications and also their refractive errors post surgery. FACO emulsification also, we give them 100 surgeries, in which 80 surgeries are done with the temporal scleral corneal tunnel, where they do the FACO emulsification with the 2.2 keratome and then extend their tunnel and place a 3-piece MMA IOL inside. The rest of the 20 cases, they make a clear cornea on the temporal side, finish the surgery, make a superior tunnel and place a 3-piece IOL inside. The allowed leaves per day are, for a year is 15 days. And this is again based on the rules set by the institution, but any emergency leaves or anything that is needed is always considered with the head of the department and head of the institution, and they're always allowed to take their approved leaves. Camps 1 every month, and night duties 1 to 2 based on the need. Like whenever there is a holiday or a festival season coming up, usually this may be only 1 or 2 a month. This simulation program that we started in March 2021 last year was a very big boon for the trainers as well as the trainee. So I will have my colleague Dr. Senthil talk to you in detail about how simulation has helped Aravind, the residents and fellows rack up their numbers in a very short term and reduce their complications as well. And since Deepak sir has already talked in detail about both side and tunnel suturing in the foam material, I will allow Dr. Senthil to explain and enlighten us regarding the simulators and its impact in Aravind surgical training.
Thank you, Dr. Shankar. It was whatever we wanted to know about training and Aravind was explained. Thanks a lot, including the stipend and everything. We'll have some discussion after the next presentation. And
thank you, sir. Thank you very much, sir. I will just close the presentation, sir.
Good evening, all.
Good evening,
my slides visible, sir?
Yeah.
So at the outset, I would like to thank KSOS for giving us this opportunity to speak about the training programs in Aravind. So I'll be continuing what my senior colleague had presented. So he had outlined the training programs in Aravind. So I would just concentrate on the simulation-based training. So a little bit about history. there were two simulators which were quite popular in ophthalmology. The first one was Lalit Vision. It was a kind of an prototype which was very basic. Could only practice rexes and few steps of aquemulsification. Then came the more popular IC simulator. So it was basically designed for vitreoretinal surgery. Then it had an upgrade which had like practice modules for capsular rexes and phacoemulsification. So then came Help Me See MSICS simulator. So it was like one of its kind high fidelity virtual reality based simulator. So if you had seen the previous simulator models had a like physical eyeball like model through which ports were there and hand pieces were introduced. Here there will not be any eyeball. So it is a completely virtual reality based simulator. So as of now, it is the first and only simulator available for small incision cataract surgery. And one more great advantage is it has all steps of M6 which can be practiced. So one more advantage which it has is it includes like the trainee will actually feel the tactile sensation when they do a surgery. For instance, when tunnel dissection is practiced, the trainee will feel the resistance which the sclera offers. So when the crescent blade enters the cornea, that resistance will be felt. For instance, if the trainee makes a premature entry and the crescent blade enters in the antechamber, then that feel of giving way will be there. So by this way, it will closely try to mimic normal surgery and a live surgery. So this way it will bridge the gap between wet lab and live surgical training, so that when a trainee moves on to live surgery, it will be of the learning curve will be much smoothened and the learning curve will be much shortened. So I just briefly overview the training modules available. It has 4 modules, with one module for the stereocorneal tunnel construction, then for capsular access and nucleus delivery, cortex removal, and IOL implantation. So inside every module there are sub-modules. So the tunnel construction module will have all these steps which can be practiced like individually or in continuous manner. Like the trainee wants to practice only tunnel dissection, he can practice only that, only parasynthesis, that can be done only keratometry. Any step can be practiced any number of times, either individual or there is a continuous module in which the trainee can practice all these steps together, like how we do in a live surgery, making an scleral incision, then doing the tunnel dissection, making a parasynthesis, injecting visco, then making keratometry. So I would just, is my video playing, sir? I just show a video.
It's playing.
Yeah, thank you, sir. So we see here a tunnel being done. So I will just pause and I'll explain the features. So normally, how we were traditionally training our trainees was in wet lab, we provide them and go outside, and then we ask them to make a tunnel. We take them classes, we demonstrate how to do a tunnel, we demonstrate what is a keratome, what is a crescent blade, then how to make an incision, how to make tunneling. And then the trainee does it on the goat side. So what it does is, we never know like how good the tunnel is. So we never know at what angle the crescent blade is kept, like how are the movements. So what the simulator adds on is it has something called guiding tools. Like it guides the trainee in their initial practice attempts. Like it will give an outline for the sclerocorneal tunnel, and then it has a box depicting depth. That means it will tell you at what level of sclera your crescent blade is, and then it will also tell you at what angle the crescent blade is held in respect to the sclera. So what it does is it will also make the trainee realize, okay, this is the angle with which I have to hold the crescent blade. So when I enter the cornea, this is the change in angle which I should do. This is the correct angle. So these things will be understood by the trainee much better. So once they have done like 10 attempts, 15 attempts, when they are a little bit like knowing what is the correct way, we can disable all these tools and then they'll be doing surgery in a normal way, so that when they graduate to life surgery, they will know they will not do any trial and error technique in life surgery. So I'll just show. So this is one more example where you can see, like if at all the train is going little deep. So all the visual cues which we see in life surgery will be simulated here. Like say for example, once the trainee goes deep, you will see that the reflection of the crescent blade is not seen. Normally we teach them you should just see the crescent blade through the sclera. You can see that it is not seen, indicating that it has gone deep. Same way around, when the trainee goes very superficial, then the depth bar moves up and you will see that the crescent blade is seen very clearly. So if at all they continue in the same fashion, so they will end up in a surgical complication. So you'll see the place where it is too deep, it will become a premature entry, and where it's too superficial, it will result in a buttonhole. So this way, the trainee can understand all these steps in a much better way before proceeding to live surgery. And then similar modules exist for rexes, hydro procedures, nucleus prolapse, nucleus delivery, so cortex removal, IOL implantation, and then end of surgery, hydrating the paracentesis to reform the AC. I'll just show small video clips of how these steps are being done. This is a module which shows like doing rexes in an simulator. So this is making paracentesis. Sorry for the change in order. Like keratometry. This is hydrodissection, nucleus prolapse, delivery, using the Simcoe cannula to aspirate the cortex. See, there are guiding tools even for cortex, which initially will tell the trainee where is the Simcoe cannula in relation to the capsular bag. So once they become little experienced, we'll switch off this. This is IOL implantation and hydration of the paracentesis. So what makes the simulator stand out is it will incorporate all the visual cues which we tell them during live surgery. Like when a good hydrodissection is done, the trainee will see the fluid wave which passes through the posterior colon and emerges through the opposite side equator. So whatever we teach in live surgery, whatever we demonstrate in live surgery, all those things are simulated so that it enables them understand every step in a better way. So the next biggest advantage of this is there is a very robust way how data is collected. So whenever a trainee has done a particular step, so there's something called performance data. That is, the simulator collects the data from that step, and then it will decide whether that step was done in a correct fashion or not. Like say for example, it is going satisfactory. That means this step has been done correctly. There are some pre-fixed data fed into the system, which the trainee should fulfill. To, for example, like the length of the inner tunnel, it is set as like 7.5 mm. So like only if it is at least 7.5 mm, you will be able to deliver a soft nucleus. So in this step, it's been done at 8.5 mm. So what was the width of the tunnel? It was like 3.2 mm. So what was the maximum depth of the tunnel? It was 0.4 mm in the sclera. So like this, whether there was any uveal prolapse during tunnel, whether it was perforation, was there any laceration, premature. So all this data is captured so that once the surgery is done, the trainee will know, okay, these are the things which went wrong. That is why the step was not proper, or these are things I'm doing correct. Also, it records the video of all these steps so that later on, a trainer or a senior consultant wants to see, they can review their video, they can make corrective action based on the video which was done. So initially, the simulator had training only for manual small incision cataract surgery. Now there is additions going on in which they've introduced modules in which we can practice multiple sphincterectomy, that is managing a small pupil, and then how to implant an CTR in case of corneal dialysis. And then down the pipeline, there are future modules which are being introduced in which planning to introduce suturing in simulator, phacoemulsification, phacoectomy surgeries, and anterior vitrectomy. So this is the simulator schedule. We have a standalone simulator course where we don't provide live surgeries. So that course is for 10 days, in which we give a general orientation of the simulator. Then we allow the trainee to practice all these steps on the simulator based on these schedule. In addition to that, we take classes on, we have PowerPoint presentations which are designed by the HelpMeC group, with which we take lectures for the trainees, and then we hand over an ebook, which is an ebook extensively designed for manual small incision surgery, so that they can read these steps before coming to the practice, which will aid them in understanding these steps much better. So as of now, till December 22, we have trained around 116 fellows or residents in simulation, of which 31 were our own PG residents. So 15 people from other institutions had come, 59 of our fellows. Then we had actually had to take 8 of our medical officers. These were the people who had finished their surgical training the traditional way. Then they were doing surgery. They had slight inconsistencies or a complication rate was high. So we made them again undergo the simulator training. And then we saw a drastic change in their surgical outcomes. Their complication rates are much reduced. And then for the standalone course, we started it recently only for external people, like 2 of them, and our internal candidates from other Aravind hospitals. So for them, it is only for 1 week. We've also published a paper in International Journal of Ophthalmology, Indian Journal of Ophthalmology, few months back, based on the outcomes of simulated surgeries done by the trainees. So the advantages over training, the traditional training is it alleviates the need for training on cadaveric eyeballs. So you need not have difficulties in procurement of the eyeballs. Moreover, like in an eyeball, you cannot practice, you have limitations, like you cannot practice more than sclerocorneal tunnel or capsulorhexis. So the trainee will not get a feel of hydrodissection or nucleus delivery. And moreover, at the max, they can practice 4 tunnels, 4 sides in an eyeball. So whereas in simulator, they can even practice 100, 200 times. Nothing is going to stop them. So it enables the trainer to provide effective feedback, so that in an eyeball, again, you have limitations. We cannot exactly judge how good their steps or how bad it is. Whereas here, it captures all the data. We have the videos which is captured, so that the trainer can go back, give them a good feedback based on what aspects to improve. And then it also has a remote training, wherein the HelpMeC company, they have their own set of qualified instructors who are exclusively dedicated for training ophthalmology residents in simulation-based manual small incision cataract surgery. So they can remotely connect with the simulator and then give their opinion. They can directly train them through video conferencing. And as I told, it also includes an ebook, which we handed over to the trainees, whoever registered for this course. We hand it over to them so that they can pre-read and then have it for future reference also. So, like this simulator, we've been using it for 1.5 years, and what we observed was it really smoothens the learning curve, like small aspects, especially when we were training residents prior. Their left hand used to put too much pressure on the conjunctiva, or they'll just lift the conjunctiva, tear up. They will have difficulty in taking instrument, and they'll have difficulty in taking instrument out. It will hit the iris, it will get stuck in the tunnel. So those things were largely ironed out. So, like how to use and forceps, all those things were they were understanding it much better, especially the tunnel aspects, the depth in which the tunnel has to be done. And we could also see that the number of rexes which were getting extended had largely reduced, like on people who were trained in simulator, because they were not doing it for the first time in live surgery. They had already done multiple times, so they know like how to do a tangential movement, where to hold the flap, all those things. Since they got a feel of it, so they were able to do it much better in the live surgery. Thank you for giving us this opportunity. Myself and Dr. Shankar will be happy to have questions, clarifications.
Yeah, but it was a really good presentation. We all got to know what a simulator does, the training and all. See, any of you have any doubts, clarifications to ask from them? You're free. I mean, 2-3 minutes we have. Shankar, I mean, just one query. I know that the simulator program is engaged throughout. In the beginning of the session, you said today you were given training to students from other medical colleges. See how does the medical college go about it? How do they approach you? Because see, the number of cases that these kids do during their PG is very low in many of the PG institutes. So if actually they get a feel of what is happening rather than just going through the book and then finishing the PG, I know it's not going to really help unless they do on human eyes and get trained. But as the presentation says, they get a feel of doing it on human eyes. So how does the medical colleges go about in requesting Aravind Group for an opportunity for their PGs to get a training and a hands-on experience with the simulator?
So thank you for this question, sir. Sir, actually, we had organized this workshop actually to enlighten or give a chance to all the medical residents in other colleges to get an exposure to the simulator. It's like they just had half an hour in the simulator where they could practice the tunnel or the rexes so that they can understand the merits, the advantages the simulator can give you. The simulator also has Uttata forceps rexes being done also. So all these things are available, and we have just given them the opportunity. So we have, they will have to now go and convince their head of the departments, allow them to come back for a 1-week schedule or a 10-day schedule. So this was just a 1.5 days program wherein around 50 doctors had participated from Mother Medical College, Chennai, Karnataka, and one doctor from Pune had also come. So we essentially what happened was we sent out the flyers to all the medical colleges within Tamil Nadu, and through the WhatsApp group, this person from Pune had come and joined us. So this is how we contacted them. But in future, if they want to join us, we have an official website where the short-term, all the simulator course has also been added on. So they just need to click over it, and all the details and the payments for this will be given to them. And in the simulator point, we have this, even the short-term course also, the one that they come for 1 month also, they have simulator practice as well as live surgery. But when it comes to only the simulator, it will be a 10-day program, and they will have to practice only in the wet lab and observe in the OP. But for the people, 2 of them who have done, one is from Armenia and one is from Karnataka, they have done this, they have excellently satisfied the discussions we have, because we not only give them the simulator, we give them the simulator as well as the both side and the Rexis box to practice, and we give them video discussions also, because they are allowed to sit along with the doctors who are in the regular courses that month. So they attend the lectures, they attend the OTs for observation, and also they get enlightened with the discussion with the seniors.
Okay, thanks a lot. You explained it beautifully, and thank you both for this that wonderful presentation.
Thank you, sir. Thank you, sir.
Yeah. Said now we will move to the next hospital, and see, I had an opportunity to meet Paneer Selvam sir. Sorry about that. So I had an opportunity to meet sir during the Coimbatore TNOA conference, and see what I told him was, sir, see, I always wanted to meet you, and it was an opportunity for me to share the stage with Sir. Had a presentation because see, I heard a lot about him, and I've seen a lot of wonderful surgeons who have been trained by Sir. So, Sir actually started Arasan Eye Hospital in the year 1997. Since then, it has made, as I said, huge inroads in all specialties of eye care. So it's basically it's hard work. See, I had one of my juniors, Soumya, who got trained from Sir. When see the energy that Sir has, the amount of work he puts on the trainers is it's huge. Actually, this program has evolved in this way as a program where the training programs are being described and explained. Was after I had a talk with Sir. So he said, see, there's no point in just discussing some surgical videos because it's happening everywhere. And so I would like to speak on the whole training process. What are the responsibilities of the trainees? What are the responsibilities of trainers? See, everything. So thank you, Sir, for guiding me in that way. And now this hospital has performed huge lots of surgeries, and it has conducted free eye camps and surgeries even in West African nation of Ghana. See, the number might be a bit old, but more than 1 lakh eye surgeries and all. So this is a huge number. So now Sharad is one of the favorite students of Dr. VPS, and he's there with us. Sir, can you please teach us?
Thank you. Thank you, Srini. Thank you very much for inviting me to this wonderful program. It's always a pleasure interacting with KSOS because most of our trainees and fellows are from Kerala. So I have a very good relationship with all of them even now. So it's a wonderful thing. And I would like to share my screen and talk on the SIC's, the training program that we have at Arasan. The thing is, Dr. Deepak told about, I'll share my screen. Is it visible? No.
Yes, sir. Yes, sir.
Okay. 1 second. Okay. Okay. I'm actually an accidental academic. I didn't start planning a training program, a structured program, anything. When I started my practice in 1997, I ventured into community ophthalmology. And soon I realized I needed hands. So what can I offer them? So I needed people and they needed training. So that is how I started my training. In fact, my first trainee or my fellow was Dr. Mohan Marcos. I think he is in Quilon or Kollam, I don't know where he is. But he was the first person. Then we have a lot of people. And it went on like this for long-term fellowship for every year. After that, a few years later, my professor approached me whether you can train me because the FACO I am not interested. The man who taught me cataract surgery, he came to me for training. It was a revelation for me. It was one of the very proud moment for me, and he was humble enough to come and learn and go, and many senior people started. Then I realized it is not only the fresh candidate who need updating, it is also people who are practicing, they also need it. So I designed a course where, and they cannot spare more time because they're already practicing ophthalmology. That way I started the short-term training program. And in 2008, I got accredited by the national board. Then we designed a DNB program. All in all, it happened that way. We became a teaching institute by accident rather than by design. So that is the next thing. Sorry. My screen is not moving. Okay. So this is a work that has been done over the years of 25 years. The red color is my free surgeries and the blue is my paid surgeries. It is a sustained growth over a period, and we have trained around 450 Indian doctors and around 230 international candidates, and it's a very learning process for me getting into this program. So how is that program? So we give both SICS and FACO, and I will first introduce the short-term training program, but the structure is there. The 15 days, 10 operation days, 3 cases per day. That is a norm. Monday, Tuesday, Thursday, Friday, we operate. And we give 3 cases for candidate, and it is a standardized teaching. So every candidate, they'll, if it is a FACO, it's only 4 quadrant. If it is SICS, it is superior, tunnel, frown incision, and sandwich technique. So this is so that any trainer can come and train. It is not a thing, and everybody will go through the same process. The whole idea of this short-term program is that we have to make the trainee understand the concept of this technique. That's the whole thing, because they are totally raw and they have to understand. So it is not the number of surgeries that they do, it is understanding the whole concept. And basically, if you see, it's only the motor skill. And that motor skill, unless they are trained in that way, repeating the same movement again and again, and insisting on how to hold the instrument, how to go, what is the thing, it takes time. So this is what a one-on-one relationship is maintained. And this is how we do. And in FACO, it is a hand-leg coordination. And in our case, it is not a structured one starting from incision to implantation. In FACO, we start with FACO first. All the other steps are same. The candidate will learn few steps every day of FACO alone, and by the time then he will move on to other steps. In SICS, it is the conjunctival peritomy, tunnel. The same time he improves, he will start from viscoelastic aspiration after the IOL implantation. So it is that way the complication is avoided, and he has got more chances, because early period, if he went into complication, his morale will go down. This is what we wanted to avoid. So it's non-linear step is one of the things that we found very useful for them. By the end of 7th or 8th OT, they'll be able to all the steps, and the 9th or 10th OT, they'll be independently doing. We all know in 15 days, nobody can master surgery, but they can develop a sensitivity to the ocular tissue. They'll know what are the things that should not do to avoid complication. The whole idea of this program is to develop the inner confidence. This surgery can be upscaled. This is a basic purpose. By the time when they go back, they can also go and do the surgery. So how do we do that? This is the method. So this is a FACO. I'm just for the example. In this part, I will be insisting on him not to push the nucleus. It is the right leg that is doing the surgery. This is what we'll be taking. You do the trenching, you press, you feel that, and you do the rotation. So these are the steps. By the time we'll be standing behind him and then doing it. Once he finishes, if he finds it difficult, we'll enter in and then take over. So this is the way we do. Same thing for, we know the last piece is always a problem for everybody, both for the trainer and the trainee. We make him experience the phaco-dynamics. It is not the end of the surgery. It is how you have to be careful, keep your phaco tip horizontal, straight, allow the nucleus to come in, don't go and chase after the nucleus. So this is the way we teach him. So he understands on that, and the moment he completes it, you know the difference. He is much more invaluable. That this experience counts a lot. We have to wait for him, understand, okay, this is how it should. There is no another movement. There's no, these are the things. Next is in any training program. This is a bugbear, the complication. So what is the complication? It's unavoidable. Any training program, but how do we manage that complication? We have structured a management protocol for the complication, because most of them it is PC rent, and in our practice the nucleus drop is very rare. I won't say it will not happen, but it is rare. But the moment a PC rent happens, what should you do? There's a dictum: you stop and come out. Don't inject viscoelastic. Close the wound. If there is a vitreous, remove that and then close it. Review and then do it again. That way, because the system is designed for an assembly line production, suddenly they stop, people will get confused, the whole thing, and we will do a bad job of correcting that complication. This has helped the trainee to learn what has happened, why is that happened. And we also know the potential hotspots where there are problems with this candidate, whether he is allowed to do it. So like nucleus prolapse or cortical aspiration. These are the areas where they make a lot of mistakes. So we give it a last moment, he gains confidence. In a step-by manner, we go so that these steps prevent any mishaps. And the staffs are also trained in how to assist them. This is very important because unless it is a back-breaking job, they will not be happy. A senior staff who can guide them, if they end up in a problem, they can call the seniors or somebody else. So it is a structured program in the way we all work as a team. And moment people come with a lot of ideas or cobwebs, they've seen a lot of videos, they want to try something because they've paid. This is a paid course. So we always have a sleeper cell. So keeping people in their way, because the patient care is more important. The complication management is one of the very important aspects in a training program like this. And the DNB program. In 2008, we had, and this is going on very well. And we have outsourced Dr. V.R. Vijayaraman is our academic director. He comes and many of the other doctors will participate. What we do is our own trainees, the DNB fellows, residents, in first year, they'll be starting doing their cataract surgery and SICS. Second year, they'll be the very good people who are very well versed. They'll be given phaco training in the second year itself. Third year, they will help me in assisting in the training program. So we have a very good structure in that. They'll be very well versed when they leave the institute as a phaco trainer. And the resident, also another thing that we found is, we don't have that of a full-time consultant in various specialty. We have visiting consultant. Each resident, DNB resident, he'll be given a thesis program in a specialty. He will work under that, and in 3 years period, that visiting consultant will train him in that. By the way, he also finishes as a resident and he becomes a consultant almost in that specialty. Like Sharath is doing his retina, he did that way. So this is also a learning process for it. It is not a foolproof one, it is not a perfect one, but it works. If applied properly, it really works. And they continue specializing. They are not given too much freedom. It is fully monitored. So we always go with this program on a SMART goal purpose. So what is a SMART goal? Specific, measurable, attainable, realistic, and time-bound. That is what SMART, S-M-A-R-T, stands for that. So I have a matrix. And my thing is, when a trainee comes here, especially a DNB resident, by the end of the course, he should do surgery independently. And my training or my resident should not go and attend any other hospital or any other program for the same purpose. That I feel I have not succeeded in importing the skill necessary for me. But over and above all these things, there should not be any compromise on patient safety and quality. This I'm very particular about. We'll come to it again. So how to run a SMART program? What are the challenges and rewards that we get? First is requirement. Like the previous speaker said, infrastructure is vital. Then there should be a continuous flow of patient. In a short period of 15 days, every day I'm offering 3 cases. I should have a program where the patients are coming in. So I should have a good community outreach program running well. And there is a good, qualified, efficient trainer is available. And there should be enough time. These are the fundamental requirement of a training program. And above all, it is a back-breaking job. It is a very thing. And unless we have a passion for teaching, passion for this training, we really happy that at the end of this course, somebody who came with nothing is able to go back with some skill and is able to go and participate in this work. That gives us a more pleasure. And the ecosystem. This is an ecosystem. A trainer and trainee and patient. Without this, this is not possible. So what is a trainer? A trainer should be experienced, yes. And he should be confident. He can handle anything. And he should be alert to any managing after the complication is not a skill. Before that, to how to prevent it. And he should be able to analyze the skills needed with the trainee. That is very important. And you should have courage, because if you're afraid, then you will not give much a chance to the student. But he has come here to learn, and if you're not encouraging him, it is a very balancing act that you should have enough courage and compassion. Compassion not only to the patient, to the trainee also. A fellow who has come, spent time, money, all the way from far off land or even where, and coming here and come to learn, you should understand his need, his want, what he wants. So we have to take responsibility. One side, the patient should go happily. The other side, the trainee. The trainer should be very aware of it, and he should listen. Carefully listen what is happening. Understand the needs and structure the program, customize that program accordingly. And for a trainee, what is expected, what we expect from a trainee is humility and responsibility. You are operating on a human eye. Very good if you have a simulator, very good if you have a wet lab, yes, all these things. But operating on a human eye is a great privilege. So you have a responsibility. And patients, they all come out with a cutting chant, the very word I hate. And it should be understandable that you have take time, everyone's skill level is different, and we are committed. And he should, the responsibility of reading is falls on the trainee, and it is only a practice which makes person. So how to make this person understand, get this responsibility, the culture prevailing in the institution. If we are very concerned about the quality of the work and the compassion towards the patient, and I think I didn't have much of a problem in all these things from them, even though they come from far off land, I don't know their background, but so far I have a good experience because people come here to learn. They are very good. And the patient. And it is the responsibility of the training institute to give the safety and a good outcome for the patient, no other. And another concern in this training program, what I call is the table time. That amount of time the patient spends on the table. You know, the training program, the patient lies on the table for a longer period. But no patient would like to, if somebody is learning in his side. So how are we going to understand, and what are the steps that we can take to reduce this table time? The patient also goes happily. So this is how. You know, FACO, everything is set up, but I am 5'10" and my trainee will be 5'1". Most of them are ladies there. So we cannot have that. So I developed 2 stools adjusting our heights so that the transition time is much, much less. And only few steps a day will make, I always have an optimum level of, for one surgical training, one case, it is maximum is 30 minutes. Within that, we should finish. So this is how we go. Any discussion should be after the surgery. And the instruction should be very crisp and clear. And preferably, it is only monosyllables. Phaco, irrigation, aspiration, stop, come out. So something like that. Not elaborate lectures. And always the trainer should take the upper hand. Do what I say. Everything else is done. There should not be any argument. I learned this. I saw this video. I don't know. In my place, my chief do it like this way. No, here you learn this. Any other thing you can go back and learn in your place, not in this place. But at the end of the day, just because you have paid money doesn't mean that I have to be subservient to you. So this is what reduces the table time. And finally, selection. For the short-term program, I don't encourage freshers. A minimum, I feel 3 years experience is needed. And I always see to that whoever we take, they should be able to go back and do surgery. There's no point training him for 15 days, putting our lot of effort, and he doesn't go and join any hospital, and he wastes another 6 months. There's no point giving training. So we really filter that and then take people, because only that these people will understand the pain of the patient, what to do on a live patient, the surgery. This I'm very, very particular, and we adhere to it. The challenges in any training program, these are the main challenges, complications, and the managing the complications is costly. It is expensive. They don't realize it. And making the patients available for all the training program. I don't like people sitting idle or each one giving that. This is not. So what we promise, we should deliver. So it requires a lot of background work is needed. And you understand the medical legal problem, any complication, whether it's a paid patient or free patient, you are answerable. And any complication rate going above, it spoils the reputation of the institution. So these are the challenges that you have in running a training program, and the rewards. It's self-improvement. I learned a lot more than my training. I learned surgery. I learned human emotions, human relations, and it helps me and giving an identity to Arasan. How will people know about Arasan without the training program? It's only a small hospital in Mofussil, South India. And the recognition that we get when we go out to another conference, and ultimately the satisfaction of training a colleague, and he happily comes back to you and then telling that we are doing this surgery, we are improving, that gives immense pleasure and pride. So I have to tell what is the right age for training? We all have idea that 30, 35 is ideal for learning or anything. But this is a student I got from Iraq. He is Dr. Nabil Mam. He once called me and then told me that he wanted to come and learn. I was surprised. And he told his age is 67. 67, how can he teach? I was a bit hesitant, but he was adamant and he came. And if you really hear the story, and it's really mind-boggling. He is an Iraqi, is a well-versed practitioner in Iraq, Baghdad. He has got his own practice there. And because of the internal turmoil, he has to escape to Jordan with his wife and 3 children. From there, he migrated to Canada. In Canada, with 3 children, he cannot practice ophthalmology. So he trained himself to become an optometrist. For 15 years, he practiced optometry in an eye hospital. The children were settled and they were into their profession. Then he said, time is enough. I want to go back to Iraq and practice ophthalmology. That time, the practice has changed. He was a prolific ECC surgeon. Now phaco has come. That's why he came to us. And what a man. And I can remember his the first day when the wife is a trained nurse, and she was also accompanied. And the first day when he said his wife was something, he rushed out of the theater. I was wondering what has happened. And after the surgery, she came and she was very emotional. Doctor, you got my husband back. For 15 years, that man has suffered and he was not able to, the job that he loved. And the moment he sat under the microscope and started doing, she said, you got my husband back. So that is the level of satisfaction. And the story did not end. He came after 3 years and finally he came with his son. This is his son. He finished his residency in Canada. He came and his son came and did a residency. These are the final moments that we have in this training program. And over a period, there is a lot of demand for finance. We balance with Indian doctors as well as, because it is, we don't take more than 4 candidates in a month, because otherwise it spoils the system. And I cannot run a hospital purely dedicated to cataract surgery training. So we have other work. So, but we understand the need, their perspective, their experience in India, and not only ophthalmology, the residency program, but also the culture and everything. It really makes you proud that you are able to contribute at a global level, taking our country forward. And this is one of the very fine experience for me in doing this. But when you come to Indian scenario, like Dr. Srini said, the training program is very, very poor. Recently, there was a ARC, AIOS workshop for the PGs. There were 150 students. When the faculty asked, how many of you are doing cataract surgery? Only 10%. Up to 12 students or 15 students were actively doing. So such a gap was there. And so there is how to correct it. First is we have to have empathy. People have joined, young mind, young body, they are coming into the course, and it is our accountability, responsibility of the institution to train them, and that should be that's a leadership issue. Unless we think on those lines, develop them, it will not work out. And this is very important, because this training program will become the catalyst. Ultimately, everyone wants a happy patient. That is what the pride, one, you qualify, you have to do your job well, whatever the monetary consideration, unless your job, the smile that you see, because you see, when you operate on a patient, the next day when he comes, this smiling face tells everything. So that is ultimate satisfaction for any doctor. We all want that. And I think what Dr. Srini has arranged this program, this various institute contributing to this, and it should be scaled up to every institute. That is what, because that is what everybody wants. And this is what every one of us also wants to see, that the happy patient, our community. And I really thank Dr. Srini for giving me this wonderful opportunity of sharing my experience. Thank you, Dr. Srini. Thank you very much.
Thank you, sir. I said in the beginning, I really wanted to meet him, meet sir, and shake hands with him, because we are all really proud of you, sir. Like what you have done to surgical training in India, and see the people, so many people coming from outside to get trained under you in India. See, we're really proud of you, sir, and a wonderful talk. And see, these sort of talks, and as Gopal said in the beginning, this is going to be seen by thousands over the next few days, and I'm sure that this is going to encourage many of the medical colleges to start a proper training program. As you said when we were discussing, you have really explained the duty of the trainers, the trainees, and all. So wonderful talk, sir. Thanks a lot.
Thank you,
thank you, sir. Thank you. Now we'll move on to the next presentation. The next presentation is from my own RP Center. See, when I passed out in the year 2000 from RP Center, so the surgical chances, cataract surgical chances were not that great. Like probably I might have done about 100 cataracts, though the total experience that you gain in RP Center is great. But now, under the leadership of the dynamic chief of RP Center, Dr. Titial, and Dr. Tushar Agarwal, who is the chairman of National Ophthalmic Surgical Skill Development Center in RP Center. So now the kids who are coming out just after the MD are real confident phaco surgeons. And Dr. Afreen Bari, who is a senior resident there, will explain how it is possible. As Paneer Selvam said, many of the hospitals they don't get to do even a single cataract surgery sort of. So from RP Center, the kids who are coming out are real confident phaco surgeons. In addition to that, like your overall train. See, when I came out, other than cataract surgery, when I was trained perfectly, but the numbers were quite low, and I could just do some cataract surgery. So, and I learned cataract surgery after joining Shankara Coimbatore. But now kids don't have to do that. Dr. Tushar, a few words from you, and then the presentation.
Yeah, thank you, Dr. Srini, for inviting us here, and we're very happy to be here today. So we'll be just sharing, what our experience has been till date. The center, or the skill development center, has always been there at RP Center, even at your time, but it was obviously of a much smaller scale when we were residents. And I think about 8 or 9 years back, this got a really major upgrade, really. I mean, almost from the ground up. And from then, we have been trying to evolve our curriculum, how to integrate, the wet lab teaching and the actual teaching in the OT, and how to sort of maximize the use of both. Of course, there have been challenges. The number of residents has gone up hugely over the last decade or so. I think when Dr. Srini was a resident here, probably one unit had about 7 or 8 or 9 JRs. Now you have almost 20 JRs in each unit. So the numbers, so we have had to balance that also to provide adequate numbers. So taking those challenges along, we have been trying to focus on maximizing the resources, the OT time and the patients and everything, so that at least when a person is graduating from RP Center as an MD in ophthalmology, they are able to handle at least majority type of phaco's, so that they have a solid foundation to begin their careers as professionals after MD. Dr. Afreen is a senior resident with us, second year senior resident. So she'll be sharing, what our system we have been able to develop over the last few years, and we like your inputs, how to improve it further, and obviously the audience also can take home a message to make their systems better. So I'll have a closing word after she finishes. So Dr. Afreen, you can start your presentation.
Good evening, sir. Is my screen visible?
Yes. You can make it full screen. Yes, absolutely. All right, go ahead.
Good evening, everyone. I am Dr. Afreen Bari, a second year senior resident, and today I am going to tell you about the RP Center experience about phacoemulsification training. There are no financial disclosures. First, I would like to tell that what are the key highlights of a wet lab. It helps to provide a risk-free environment to residents and trainees. It gives a hands-on experience for developing techniques and confidence for surgical performance, and it addresses various technical, ethical, and practical issues of surgical teaching. Now, what a trainee or a resident, what he can learn in a wet lab, what are his scopes? The first thing that a resident or any trainee needs to learn is posture and hand-eye coordination in ophthalmic microsurgery. His balance with operating microscope, the basics about surgical instruments, what they are used for and how they should be used, the ideal way of using them, and phacoemulsification machine, the basics and the phacodynamics, and the actual surgical skills. Before proceeding for the actual surgery, there are 80 to 90% of the things that can actually be learned in a wet lab. So wet lab curriculum, we have a wet lab curriculum which basically aims to teach and enhance the fine motor and proprioception skills of the resident, making him confident to work with the microscope and comfortable with the foot pedals and switches. It helps to demonstrate proficiency in working in small surgical field as both assistant as well as the surgeon. He can learn the differences in various phacoemulsification machines and the setup of the machines. The foot pedal settings can be learned. He can demonstrate and he can learn corneal and scleral incisions and even other surgeries like perforation repairs, glaucoma surgeries on animal model. Various step-by-step teaching can be done of extracapsular cataract extraction and phacoemulsification. These can be done on either cadaveric eyes or animal models. The basics about ophthalmic sutures can be given, and the ability to pass corneal, scleral, and other kind of sutures, these can be taught. Now, the ophthalmology residency at RP Center, as each resident over the period of 3 years undergoes twice rotation in 6 units. And based on the unit he is working in, every week he gets 2 days on which he is scheduled to go to wet lab and do his training. Like for our unit, on Wednesdays and Saturdays, it is scheduled for all the residents to attend wet lab training. If we divide the ophthalmology residency of 3 years into semesters, the first semester junior resident, when he comes on these days, he is expected to visit wet lab and learn the basics of the machine, the microscope. We have one dedicated senior resident and numerous staff members of wet lab who excel to teach these skills. They are there to teach the basics of the microscope and the machine to the initial teaching to the junior resident. They're taught about the instruments. They make him comfortable on the machine and the microscope. And the basic ECC training step by step is given. And that after his training, multiple cases, as he has done on Go Type, we ask him to do one examination is done on a Go Tie under the supervision of the senior resident, and a module completion certificate is given once the senior resident finds him competent enough. Once he attains the certificate, only after that he is given first extracapsular cataract extraction case. Now this is example of one of the junior resident who has just joined 15 days back. He comes twice a week minimum for his training. For the basics, initial few days he has been asked to do suture practicing. After we have taught him how to pass a 10-0 monofilament suture, he has been, as shown in the right side figure, marks are being made on the thermocol, and that is mounted on the mannequin, and the junior resident is made to sit comfortably and manage his eye and foot coordinately, so that he is able to pass sutures, not just able to pass sutures, but to pass sutures on the marked lines perfectly. Initial few days he does this suturing. Once he is comfortable with these things and is comfortable with the suturing practice, he is taught stepwise the steps of extracapsular cataract extraction on Go Ties. Step by step incision making, injections in the eye, capsulotomy, wound extension, lens delivery, use of Simcoe irrigation aspiration, IOL injection rotation, and wound closure. Step by step, these things are taught based on the pace of the learning the junior resident has. And once he is comfortable, he is asked to repeat it over the weeks. Once the senior resident feels that he is competent enough or he is confident enough, he undergoes an evaluation test on goat's eye under the supervision of the posted senior resident. He is evaluated on various steps. Modified Oscar scoring system is used for evaluation based on various steps like incision and paracentesis, viscoelastic AC formation, capsulotomy, hydrodissection, lens delivery, irrigation and aspiration, IOL injection rotation, and wound closure. If the senior resident feels that the junior resident is competent enough, he is issued a certificate, after which he is allotted his first case under supervision. Now, this is one of the cases, which is the first case of one of our junior residents, which they have done in first semester of junior residency. These are how they have been, even in their first case, confidently able to deliver the nucleus and pass beautiful sutures. Now, as the resident comes to his second semester, he is given phacoemulsification training. He is taught on those days where he goes to the wet lab, he is taught about the phacoemulsification machine. He is taught about the foot pedal settings. Then he is taught about capsulorhexis, which he is asked to perform both on goat's eye as well as on simulator. Once these things are done, he is taught phacoemulsification step by step. And after all these series, he has been taught, he is asked to do cases of phacoemulsification with IOL implantation on goat's eye. And then he repeats this over weeks and weeks. Once the junior resident in the second semester feels confident enough, he undergoes an examination on goat's eye under supervision of the senior resident. And senior resident, again, this is the simulator on which rhexis practice can be done. Again, using the modified Oscar scoring system, the senior resident grades all his steps. And these include incision and paracentesis, viscoelastic injection, capsulorhexis, which is again divided as flap creation, follow through, and completion, hydrodissection, phacoemulsification, which also includes probe insertion and the stability he has in the anterior chamber, nucleus chop and sculpting, rotation and manipulation, irrigation and aspiration cortex removal, IOL insertion, rotation, and the final position, and wound closure. Based on these steps, he is given a score. If the evaluate SR thinks that he is competent enough, he is allotted his first phacoemulsification in the second semester of his residency. Now, this is one of our junior residents doing his first phacoemulsification. Now, this is the happiness which on his face after doing such a clean case. We can see that IOL is in bag and he has done a clean surgery. Now, from 3rd to 6th semester onwards, the junior residents are taught to work and upgrade the quality of their surgery. Each and every step is evaluated and is worked on specifically. Weekly review of the case videos and informal question and answer and discussion is done by faculty, and they can informally show their steps. Each case they do, they record it and they discuss their problems, and they are able to, and they are being taught that what went wrong, what could go correctly, and what they could, what is the problem with them. They are being taught. The correct videos are also being shown such that they should be able to identify their lacunae. Then after that, they are expected to work on their lacunae specifically so that they upgrade their surgical skills. Now, on the left side, we can see that there's one resident who had problem in rhexis. So he worked continuously on the simulator for that. Simulator, various modules can be done on that, but it is better for rhexis practice as it is very sensitive that even a slight movement, it identifies if there is a lens touch deeper at a deeper level or it is endothelial touch. It is very sensitive. So it helps the resident to have a very sharp and controlled hold on the rhexis forceps or cystitome. Now, this is on the right hand side. There was a resident who had difficulty in controlling his foot pedal settings. So he was being specifically taught, targeted approach was done to improve his problems. Now, not just for junior resident, even senior residents, they have extended scope of in the wet lab. This is the model which shows, it was compiled by Dr. Amar sir, that even in our wet lab, we have now, what all can be done, even for senior residents, scleral fixated IOL, kind of trabeculectomy, squint surgery, traumatic injury repair, even evisceration, phakic IOL implantation, lamellar procedures, even ocular surface procedures, valve replacement, even these are now being done in our wet lab, which also help the senior resident. Now, this is a virtual, this I've made a video to just give you a tour of our wet lab, which is the National Ophthalmic Surgical Skill Development Center. As we enter the wet lab, on right hand side, there's a first room where the classes are being held. On the left hand side, this is the simulator, which is the virtual reality lab. The residents can work on it and to specifically improve their skill. It is open from all the working hours. It's open. They can come. Here is the entry part. This is our lab. This is the first room. Then as we go in the second room, these are the staff. They are very helpful. This is one of the workstations where Manipin is mounted, and this is the phaco machine. We have one of the, this was one of the machines in Infinity. The microscope is there. There is a screen, and there is whatever the junior resident is doing, we are able to see on the screen. There are numerous working stations. All the instruments are there that the junior resident can see. Now, this is one of the working station. Now, this is the 5th working station. We have 5 working stations, and even we have Centurion on the 5th working station. So, Infinity and Centurion, both machines are available for the resident. Now, coming to the take-home message, wet lab, it is a very useful tool it can help the junior resident get a full experience before doing the actual surgery. About 80% of the things can be learned, like the microscope basics, phaco-dynamics, foot pedal settings, and step-by-step surgery, which will help him not to falter at various steps. And even in his first surgery, he'll be very confidently and beautifully doing the surgery. It will help to create a stress-free environment where the residents can find their lacunae. They can discuss, see their record and see their surgical videos and discuss with the faculty that what is the problem, and they can specifically work on those particular things. A planned schedule where various residents sit and they discuss together, it will not only help just one person, but numerous case scenarios, and through numerous cases, multiple people can learn at the same time. So before doing the mistake, you can actually prevent it. Coming to this, that every person who is an expert was once a beginner. It's just practice before you actually become perfect. And I would like to thank all my mentors and the center for giving us numerous opportunities. Thank you, sir.
Thank you, Dr. Afreen.
Yeah, we can see Tityal sir, Namrata ma'am.
Yeah.
Okay, sir.
Yeah.
My co-guide.
Yes.
Yeah, Dr. Shah.
So, as she nicely summarized our working schedule, so the focus is on two things. One is that before they step into the OT as a surgeon, they should be proficient in goat's eye, doing that surgery in goat's eye first in ECC. So we were trying to make it mandatory, and since about 3 years now, it is mandatory. So before you do your first ECC, you have to pass that exit exam. Little bit clarification. We have modified the Oscar scoring from the regular Oscar scoring to be made it applicable in goat's eye, both for ECC and phaco, and the score has to be either 3 or 4 in each steps. Otherwise, they don't go ahead. And once we give that certificate to them, they take it to the respective unit and they get their first cases of ECC. And simultaneously in the wet lab, they get started on the phaco training. And the same thing is repeated in phaco. Once they are confident, they will ask for an exit exam, they will take it. And once they pass it, they take the same certificate and they start getting their phaco cases. The other thing which we do, which has really sort of made a change, I believe, is that the weekly review system. So we encourage them to record all their cases. And so on a weekly basis, we review them, on a weekly basis. So on every, for example, in our unit, I do that myself every Saturday. So they are posted with us for around 3 months at each time. So what I do is I take it step by step. So in one session, we will just do incisions. So we collect all their videos and all their incisions are edited. And so we will go through. So one trainee also, the group of JRs will see 20-30 incisions in single go of their colleagues. See, it's a very unfair comparison. If they see a proficient consultant doing an incision who has done 20-30,000 surgeries, and then you ask them to do the same thing, it's very unfair. But when they see, 30 incisions made by their peers who are slightly junior or senior to them, then the actual learning or training comes into play. And then they learn to sort of identify, okay, I had a similar problem, or I had a similar issue, or I had a similar leaky incision, or my position of the incision was not correct. Okay, so I'll do that. And so that's how we do it. And along with that, so the step by step, so it takes about 10 classes to go through each step individually. And along with that, some people also show their entire cases. And that's how they sort of keep improving. So this hand-holding, I think, has really helped. And by the end of fourth semester, fifth semester, they really sort of become quite independent in phaco. And by that time, they are wanting to, learn more challenging cases and all those things, which we, of course, try to teach them. So that's about it. And senior residents, they also try to learn, and even not the various advanced surgery, especially in a cornea unit, things like DSEC, DMEC, penetrating keratoplasty are quite easily learnable. We also get some eyes sometimes from the eye bank, human eyes, which are not suitable for corneal transplantation, the eyes with some infections or something like that. And even those are used. And even as a faculty, I sometimes when I have to try a new surgery, I also use the wet lab. When I started took up iris repair about 15 years back, I practiced a lot on in the wet lab before I actually started doing those cases. And things like SF IOS and all faculty have sort of learned it in the wet lab before doing it. So it is being used quite nicely, I would say. And that's from our side. And if there are any questions, and I'll be happy to answer.
Dr. Tushar, it's come a real long way from when I was there.
Yeah.
But see, your hands are full, right? Like it won't be possible for RP Center to take trainees from outside. Like it's almost 3 times the junior resident number, and senior residents also. But see, isn't it the responsibility of the Apex Institute in India to make sure that the training in other institutions happen in a proper way, and take a lead on that, like training of the trainers, and or a program where it happens in the other institutions. That's Selvam.
This has been on Professor Titial's mind actually since about last couple. Just before COVID hit, actually, we were planning to do a 1-day course. For to begin with, we were planning to do it for people in new aims. To run a similar program to share our experiences and best practices. To begin with, the idea was to the newer aims, the faculty their representatives can come and do a 1-day course. And to supply them with all the materials which we have collected, and to do sort of a 1-day course for them. And then this was just before COVID actually, and then COVID hit, and then 2 years went by. But it has been on our minds to because even if we can't sort of take in extra residents on a regular basis or extra trainees, we do get, by the way, government agencies can send their trainees to us for there are different types of programs available for people who are in government service. So we get trainees from armed forces, we get trainees from other government hospitals. There are 2 types of trainings available. I think one is observership, which is for 4 to 6 weeks, and the other is a full-time training for 2 years. So those are available through the dean's office or the registrar's office. And we try to accommodate, especially people who are local in Delhi or NCR region and want to, have some kind of hands-on experience in the wet lab. We do try to accommodate them through the proper channel also. Having said that, we try to. We are trying. Sir has been telling me to do this program. So now that I've got a sort of a booster dose also, so maybe we'll. Get it started this year. 1-day program.
We are outside and we see a lot of
these are
coming in.
These are national resources. They should be available, or the experience at least should be available to everyone. I mean, they are not private resources. All these labs and all. A huge amount of government resources have gone into building such a facility. It is better than a lot of OTs, regular OTs. The machines and all, infinities and centurions and the microscopes, I mean, I totally am on board with that, maximum amount of people in India should be able to make use of it, even if not directly, indirectly. And I think I'll take it up. It was just kept in cold storage. I'll take it up again with sir and probably get it started by this year. A 1-day course in how to run a phacoemulsification training program in a medical college or a training center. And we'll be
Why I'm insisting on that is like, especially for girls, it's see, unless they get that basic training during their post-graduation surgical training, see, it's the nature. They have to get married at the end of their post-graduation. Then they can't go for fellowship. See, if you don't have enough basics during your post-graduation, without a fellowship, it's a zero surgery. Then they have kids and all. See, now more than 95% of the postgraduates in Kerala are girls. So I think the training process in the other medical colleges have to be improved, and surely AP Center should take the lead.
Yes. No, we'll start working on this again. And the other mindset shift is that there are a lot of things, even if you, because there's no point waiting for a formal wet lab that, okay, I will wait and I will not do anything until I have a room and a dedicated microscope machine. There are a lot of things which we are trying to, which we were sort of thinking, with this one-day program, that there are a lot of things, even with a regular OT, without the patient, you can make the trainee learn. Like there is the entire hardware part, software part, the machine part, the microscope part, the dry practicing part can be done in off hours when there are no patients in the OT. The regular OT can be used as a wet lab. Of course, there will be no go ties or anything, but there are a lot of steps which can be, a lot of things which can be taught in the, only that mindset has to be there in the minds of the trainers there. So that shift also, I think, is required. I mean, we should not take it up as a, the only thing is that training of people should not be taken up as a favor to them. One of my slides, last slide in my FACO course, which I do, says that when you teach your junior, it is not a favor you're doing to them. It is the debt of your teachers that you are repaying. And that mindset has to be there. And once that is there, I think everyone can do a better job. That's my thinking.
Yeah, thank you, Dr. Tushar. It's great to have leaders like you there. And
thank you for inviting us.
And thank you, Dr. Afreen. Wonderful presentation.
Thank you.
Thanks a lot. Thanks.
Bye.
Thank you.
Bye.
Then the next presentation is from the Vittela Eye Institute. And see this Vittela Institute and Prabha Clinic is one of the preferred training centers for kids from Kerala. So why I called up Dr. Praveen was, see, one of our juniors in Kanangad had gone and got trained there, and she was very happy with the training there. And the Vittela International Institute of Ophthalmology is a tertiary ophthalmology center in Bangalore, Karnataka, was founded by late Dr. Ramachandramurthy in 2001, who was a renowned ophthalmologist, and is emerging as a center of excellence and training and very specialist of ophthalmology. Sri Keshava Trust, which manages the hospital, has started in a small way in 1981 as Prabha Eye Clinic, Bangalore. Hospital is known to provide quality and affordable care to patients. So the chairman is Dr. Praveen R. Murthy, and the medical director is Dr. Krishna R. Murthy. And this, as I said, it's a great center to get trained in. And we have two dynamic trainers from there, Dr. Vandana and Dr. Sindhu. Dr. Vandana is Dr. Vandana Saira is a medical superintendent, consultant cataract, cornea and refractive services, and Dr. Sindhu is a consultant in cataract and general ophthalmology. Dr. Vandana, can you? You're muted. Dr. Vandana, you're muted. Yeah. Okay.
Thank you, Dr. Sreeni, for your kind words.
No, you got muted again, Vandana. Yeah.
Thank you, Dr. Sreeni, for giving the privilege to be a part of the CME series. And definitely, it shares our passion to teach our freshers into what is the basics of training they need to undergo, and with respect to cataract surgery, which is the most common basic surgery that they need to know before they come into practice as ophthalmologists. I'll be sharing the screen. Sir, my slide is visible,
Yeah,
sir?
yeah, visible.
Yeah. Okay. Okay, on behalf of Vittela International Institute of Ophthalmology and Prabhai Clinic, I would wish all of you a very happy new year. And coming to what the topic of your series, Perfection in Cataract Surgery. As residents, when we passed out, we were not told it's an ongoing pursuit. We thought at the end of getting the MS degree, we were all going to be excellent cataract surgeons. And as I said, the commonest surgery that is done is the cataract surgery. And when they go on for their career requirements, the first thing that is asked of them, whether it is a private practice or in medical colleges, a basic cataract surgery with a skill in phacoemulsifications. Now, coming to how a beginner or a fresher would feel is depends on where the loopholes in their basic training. Surgical training is not like our theoretical knowledge, which can be read from the books and can be learned by heart. You have to experience it, and it involves a lot of hard work. And of course, it involves both the trainer as well as the training. Now, there was another scenario that cropped up, and which has definitely given a lot of challenge to our students. That is the COVID-19, where they missed out on their practice. They were not in their specialty of course. And then, of course, the surgical hands-on was very minimal. Now, what we want to do from our training schedule is a focused training with adequate exposure and proper mentoring of our candidates. Now, we offer a manual small incision cataract surgery short-term fellowship program, which is a 3 months duration. Eligibility is anybody who has passed their diploma, masters, or DNBs, and even practicing ophthalmologists who would want to come in and hone their skills, they are welcome to do so. However, this is a paid fellowship with a nominal stipend, and we do give them an institutional fellowship certificate. Now, coming to what is the outline of our fellowship program. Initially, the student is oriented into the training program. We ask them to undergo wet lab practice sessions by presentations in terms of theoretical knowledge, the basics, and video-assisted learning. And they will have additional duties like the outreach clinics, camps, and night duties, other than the cataract surgical exposure that they get during the program. We do have a wet lab, which has a good microscope, phacoemulsification basic machine is there, and dedicated section has been allotted so that they can, which is off the OPD and the OT area, and they can utilize it any time of the working hours. Now, all the residents and fellows are encouraged to undergo these wet lab sessions. The cadaver eyeballs are provided, bow ties are provided. There's a mannequin which is there for learning phacoemulsification with a phaco eye, and basic training of suturing practices can be done in the wet lab. Now, in the wet lab, they are taught how to focus the microscope, then what are the instruments that we utilize in our OT, and the phaco machine and its basic handling as well as the parameters are taught to them. Each resident first will do their practice sessions in the wet lab. and they will be reporting those to the concerned senior consultant. Then once we go through their wounds and we are sure that they are able to handle tissues properly, they are then assigned cases. Initially, they will start from learning small incision cataract surgery, and then depending on their competency in their final year, our residents will be given steps in phacoemulsification, whereas in candidates who come for small incision cataract surgery fellowship, they will be taught small incision cataract surgery only. Now, coming to what happens in the OR once the wet lab sessions are done. It is not a one-day affair. The wet lab sessions, they need to be done quite frequently, since it's a short-term fellowship, and they need to hone their skills within 3 months duration. So a frequent wet lab sessions, as well as depending on how they are picking up, we will be getting them into OT. We have a 5-day OT in our hospital, and all the 5 days, the small incision cataract surgery fellow will be posted into the OR. Initially, few days they are posted into the block room posting so that they get accustomed to the system of our practice, and the step-by-step training will be taken up, and starts from observation of trolley setting, how to drape the patient, and then cases are allotted to them each day, and they will be given a designated step to do. And always there is a mentor with them who will go through each step of the surgery. We assign the cases and the mentor at the beginning of the surgery itself. It comes onto the OT list, so that our fellow knows with whom he is getting posted. And we always insist the patient is been seen on slit lamp prior to them coming into our OT. Now, there is a competency assessment also, which we do as we observe the fellows. We follow the ICO Oscar competency for SICS and phaco. Generally, it has many aspects to it. It has been very nicely explained by Dr. Afreen of RP Center. The same thing, few are procedure related, which involves draping till the last step of the surgery, and the global indices, where it is with respect to the wound, eye positioning, tissue handling, and spatial awareness. So we can grade that candidate as to how he is, whether he's a novice, whether he's a beginner, advanced beginner, or he is competent enough. Once he is competent enough, then he can be moved to the next level of procedure. That is, if it is a resident, he moves from doing manual small incision cataract surgery to phacoemulsification procedure. Now, there are a few other long-term fellowship programs where we do offer cataract training as well in our institute, like glaucoma, comprehensive ophthalmology. However, these are 18 months to 24 months of the surgery, 24 months of duration, depending on the subject that the fellow would like to choose. I would like to highlight about a comprehensive ophthalmology fellowship program. This program is a 18-month duration program, and it gives exposure to all the subspecialties. The fellow is trained in SICS, phacoemulsification, pterygium, and DCT, and basically a little bit of medical retina training. And since they handle outreach clinics, camps, and they are going through academics, and they will be honed as a basic ophthalmologist, and they can start their private practice or can go back to their institute and determine their area of work. Those people who find their interest in any of the other streams, they will be able to build upon that. Other fellowship programs like glaucoma fellowship, 18 months duration. Again, we do offer them manual small incision cataract surgery as well as phacoemulsification other than the glaucoma surgery procedures. We have medical retina and uvea and vitreoretina fellowship programs in our institute, which are the long-term fellowship programs. I would like Dr. Sindhu to just go through the way we train our fellows with respect to manual small incision cataract surgery and the highlights that we would always emphasize during our training. Thank you, sir.
You can unshare, Dr. Vandana.
Okay.
No, Vandana, you have to unshare only, then Dr. Sindhu will be able to.
Okay, okay. So is it done?
No.
It's not done.
There has to be a place where it says unshare. It's just move your cursor. It'll be there on the screen somewhere.
Okay. Yeah. Sorry, sir.
Yeah. Okay.
Thank you.
Dr. Sindhu.
Sir, is it visible, sir?
Visible, but it's not in a presentation mode. And it's okay. It's okay. You can.
Okay. Good evening, everyone. At the outset, I would like to thank Dr. Srini, sir, who's the chairman of Scientific Committee of Kerala Society of Ophthalmic Surgeons, for giving me this opportunity to present our manual small incision technique in this CME series. I am Dr. Sindhu. So coming to the case selection for training purposes, the cases for the training candidates are graded depending on the level of difficulty. So beginners are usually given cooperative patients, bilateral phakic patients are preferred, patients with good pupillary dilatation are selected. Basically, nuclear sclerosis grade 2 to 3 is selected for such beginners, and care is taken not to select a very deep set or a prominent pro patient. And care is also taken to see that there is no obstructive airway disease, and patients who cannot lie on the operating table for a long period of time are usually not selected for beginners. All the fellows are instructed to explain the patient with regards to the procedure, that is, with regards to the block and the duration of the procedure. They're also instructed to do a thorough preoperative examination on the slit lamp before the surgeries. The fellows are also instructed to see the completed case sheets, the biometry sheet, and the availability of lenses, both the PMMA and the 3-piece lenses in case of any eventualities. So coming to the surgical technique, so once the patient is painted and draped, the speculum is inserted and peritomy is being done. The ballpoint cautery is being done. Generally, we decide the incision of the tunnel depending on the case to case. That is, in case of a glaucoma patient, the incision can be shifted temporally or superatemporally. And even based on the K readings, we decide the site of the incision. And the students are assigned a senior consultant who mentors and who gives inputs on each and every step of the case. So in such cases, like where the tunnel is being done, the students are instructed to make a proper pockets, and the rexis is being done with the help of a bent cystitome. In any case of complications like a rexis runoff, the assigned consultant takes over the case. Generally, rexis is being taught to all our candidates, because in any case of eventualities like a PC red, we always have the option of placing the lens in the sulcus rather than going in for a secondary IOL. So only in cases of a rexis runoff or in difficult cases, scan opener techniques are also being taught to the students. Usually, visco expression is being taught to all our students. This we have noted that the transparency and the clarity of the cornea is very good in our post-op cases with visco expression. And in the placement of the IOL is taught to, in the back placement of the IOL is taught to all our students. The students are being monitored every step by the side scope. And in case of any difficulties, the case is taken over, making sure that the patient's eye is the priority. So in case of any difficult steps, suppose a fellow is having difficulty in making tunnels, then they are reassigned to the wet labs. They are told to practice on the goat's eye or on the human cadaveric eyes. And later on, they have to come back to the OR. So there is one more video showing the technique in a mature cataract. So this you can see is a mature intumescent cataract. So here the students are guided with the use of trypan blue for capsule staining purposes, and making sure that they adequately fill the viscoelastic substance to prevent a rexis runoff. Additionally, they are taught the use of rexis forceps in case of any difficulties based on their competency levels. And the students are also instructed to do the post-operative rounds of their cases and inform the assigned consultants regarding the post-operative vision and the intraocular pressure and any complications such as hypema or hypopyon or a decentered IOL. So all these cases have to be informed to the assisting surgeon. They're also required to maintain a logbook and make a note of all the difficulties in each and every case. The classes are usually taken on Saturdays with respect to both the theory as well as the practical aspects, and consultants are freely available throughout the week to answer their queries. Thank you, sir.
Thank you, Dr. Sindhu. That was the first instructional video for today, and it was a good one. And see how many fellows or trainees do you take every year?
Sir, presently we have 7 postgraduate students, both the primary and the secondary DMB. And this SICS program is 1 per 3 months, sir. So every 3 months, we take only 1 SICS fellow, okay, and 1 comprehensive ophthalmology fellow every 18 months. So we have an overlap, like 1 year overlap.
Okay.
And 2 glaucoma fellows are also there presently with us.
Okay.
So these are the people whom we train for cataract surgery.
So what is the waiting list for your that short-term SICS? Do you have a waiting list there, or?
Yes, sir. We definitely have a waiting list. Many of our students who go back to their institutes, they recommend their friends for our short-term fellowship. We have a waiting list. Presently, there is one who has joined recently, and 2 more are on the waiting list.
So what if somebody wants to do the short-term fellowship? Basically, that would have a lot more takers because because of many family situations and all. Some people will be already in practice. They can't stop everything and go for a fellowship. So what is the process that where do they apply for it? How do they apply for the short-term training and all?
So they usually send an email, sir, to our institute address, and the email will be forwarded to our medical superintendent, Dr. Vananda, and she takes a call after discussions.
Okay. Thank you. This is basically what I wanted to see. What each institution to really explain what you have to offer to all those kids, and even those who are really into practice, probably even in their 40s, who really want to see. Dr. Selvam was telling about a 67-year-old Iraqi man coming. So this is good. It's great that institutions are doing this training programs. Thanks a lot. Thank you,
Thank you,
Vandana.
sir. Thank you for the opportunity.
Thank you.
Thank you, sir.
Thank you. So next, 1 second. Okay. I'm sorry about that. Let me. Okay. So now we have see, like Dr. Asim Sil is a person. I mean, I've actually talked to him for the first time for this program only. Actually, I called up Dr. Debashish and Dr. Samar Prasad to get their involvement in this program. They said, Sreeni, we don't have that sort of a program. And Dr. Samar Prasad said, we have Dr. Asim Sil, who is doing great work in this aspect, and they're from Vivekananda mission Ashram Netra Nirmay Niketan. It's a comprehensive eye care program. It's basically a charitable work that they're doing, and they're doing tremendous work going to the remotest of remote villages, providing them free eye care, affordable eye care, and I believe they have two branches, and so they covers about a population of about 15 million, and majority of the surgeries that they do are free, and they have an excellent structured program of training all those who come for short term, long term, and all. So, sir, can you start your presentation?
Yeah. Good evening, everybody. at the outset, I would like to thank Kerala State Ophthalmological Society and especially Dr. Sreeni for inviting us. And I would like to share some of my feelings. Like I did my post-graduation in Aravind Eye Hospital. So I learned cataract surgery there. And towards the end of my PG-ship, youngsters like us, we were made trainers. So the first gentleman whom I mentored was 30 years senior to me. So so that was my first experience. So I got the feeling that cataract surgery can be learned and cataract surgery can be taught as well. So when I left Aravind and joined this place where I am now, way back in 1995, I came to this place with the surgical skill of ECC with 5 to 7 sutures. And later on, when I used to visit Aravind Eye Hospital for various reasons, and I am grateful to Dr. R.D. Ravindran, who affectionately gave me a chance to watch his surgeries in the theater. So just by watching him through the observer scope in the operating microscope, I was able to pick up SICS as well as phacoemulsification. So that gives me the confidence that it can be taught, it can be learned. So when we started working in a remote place in West Bengal, the juniors got attracted only for the scope of learning. So now in today's discussion, we have Dr. Sumanto Bera. He is a very passionate cornea surgeon. He is trained in Sankarananthan, and Dr. Subra, she is also trained from Aravind Eye Hospital and LB Prasad. Both of them are cornea surgeons. Sumanto is more close to the trainees in our hospital. So I would like to invite Sumanto to talk about kind of training we are offering and what kind of exposure they are getting and how much we are offering to our trainees. So just hear from our rustic experience. Over to Sumanto. Sumanto, you are muted.
You're not audible, Dr. Sumanto. It's actually you're not muted also. Some issue with your laptop. No, can't hear you. No. Asim sir, you can continue.
Okay. Sumanto, try to fix your problem. And in the meantime, just let me share the principle of teaching SICS in our hospital. So let me share some experience which I had in the city of London. I had to live in the city of London for some time. So when we used to travel by tube rail, and there were certain railway stations where the gap between the train and the railway platform was little more than usual. So there used to be security personnel. They used to stand there and constantly tell the passengers, mind the gap, mind the gap. So when I started looking at the complications of small incision cataract surgery, then I understood that there is something to do with the gap in small incision cataract surgery as well. So the principle of our cataract surgical SICS surgical teaching is mind three exits. It's like imagine a nucleus is coming out of the eye. So the first exit of the nucleus is the capsular opening. So whatever may be the method of capsulotomy, either it is Rexis or can opener, the first exit should be adequate. And the second exit for the nucleus is the pupil. So we should always give due attention to the size of the pupil, rigidity of the pupil. And the third exit is the corneoscleral tunnel. So that also should be adequate for the density of the nucleus. So if these three exits are adequate, we finish the surgery with least complication. So I always tell our trainees that mind three exits. If you can remember these things, you will have a very smooth surgery. So Sumanto, can you test your voice now? You are not audible. Anyway, let me share the screen.
Now audible?
Yeah, it's now audible. Okay, you carry on.
So I have a short presentation. Is my slide is visible? Slide are visible?
Yeah, visible. Just make it full screen.
Okay.
Yeah.
So thank you. I'm sorry for the delay. So this is our candid photos of our hospital. The residents that stays in a very natural places with very close to nature. So at Vivekananda Mission Ashram, we had two branches. One is at Chaitanyapur, that is in East Midnapur, that is in a semi-urban and rural area. Another one is at Amtola, 24 Parganas, that is about 30 to 40 20-25 kilometers from Kolkata. So we have both of long-term and short-term teaching program. First, I will talking about the long-term of 18 months comprehensive training program. It is a stipend program. Initial 1 year we used to give 45K. Initial 1 year. Sorry for that wrong entry. And last 6 months we used to give 50,000 rupees to the trainee. All the postgraduates who has a MS, DNB or DO completed, they can apply for the program. We used to take one candidate per 6 months. They used to have OPD, evening, they used to work in the OPD. They will also have evening pre-op and post-op rounds along with emergency, and they will obviously have duties in the war. They will also work in the camps. Usually they used to get one camp duty per month, and there will be once a week academic discussion where we used to discuss about their progression in the surgery. They used to put some theory classes. We used to discuss about the SOPs of our institutes. There is also a wet lab. We used to do wet lab after the completion of regular hospital program duties. And there is a very elaborated library, and that is open from 12 noon to 8 p.m. The candidate used to have 10 CL casual leaves and 10 medical leaves per year. Training consists of a compact, comprehensive training program to create a confident ophthalmologist. That is our main goal. And Sir has already explained about his own experience and how he has started the training program in this remote area of West Bengal. These consist of cataract training, and our aim will be to create an independent surgeons, and all of our trained 18 months program candidates are now doing independent surgeries in their own areas. Glaucoma, we used to give training on diagnosis of and medical management of glaucoma, and last 6 months they will also have some hands-on on doing trap surgeries. And cornea, we used to have a cornea OPD along with a attached microbiology lab. They used to have with all the cornea, see all the cornea patients along with the corneal ulcers. They used to do scrapings there on their own, and they used to see all the slides in the microbiology lab. They used to have the opportunity to observe the different sorts of corneal surgeries like lamellar keratoplasty, penetrating keratoplasty, pterygium surgery, ocular surface reconstructive surgeries. And in last 6 months, we used to have some hands-on on pterygium surgeries. Oculoplastic clinic, they used to see the OPD and work up all the oculoplastic patients like chronic DCT, ptosis, entropion, ectropion. If they are interested, they will also get doing DCT surgery in their last few months of their training program. Retina, we have a detailed retina OPD along with OCT, DFA, ICG, and they used to follow the retinal surgeons in our OPD. We will have a full-time retina consultant in our OPD, in our hospital. They will also get observing the different sorts of retinal surgeries like RD and vitrectomies. Pediatric ophthalmology, we also have a pediatric ophthalmology facility. They used to do all the workup in squint, and they will get opportunity to measure the squint on their own. Few lines about short-term training for postgraduates in ophthalmology. We will have the opportunity to enroll in short-term training program. There are different sorts of durations. For SICS, we have a 4 and 8 weeks of SICS training program. For FECO, we will have a 4 weeks of SICS training program, and we will also have a combined 4 weeks of SICS and 4 weeks of FECO emulsification. All these are actually paid program. So all these costs are, that is 25,000 and 50,000 for the SICS and 60,000 for the FECO. These are excluding the cost of living. Candidate has to send a request mail with their CV to our designated email address. I will put it in my last slide. So these are compulsory residential program. The short-term training has to attend the pre-op rounds. Usually the long-term training used to have 2 weeks per day, but short-term has to attend daily in the pre-op rounds. And short-term trainee has to see their own cases, whatever they are going to operate in the next day. They will posted whole day in the OT, and including they will observe the senior surgeons, along with they will do surgeries at a designated time. So we have a basic wet lab training. If a short-term training or long-term training used to enroll us in the training program, we have to see in the wet lab whether they are confident enough or competent enough to do surgeries on human eye. So initial 3-4 days we have to observe in the wet lab whether they are competent enough, and according to the feedback from the senior consultant who is observing them in the wet lab, we used to give them the duties in OR. So initially a few months for the long-term training, and the first week for the short-term training, they will have hands-on with under strict supervision from a senior consultant. And after that, if they are competent enough, then only we used to give them opportunity to do independent surgeries. for post-op round, all the post-op patients done by the short-term training and initial few months of long-term training will be evaluated by the consultant, and they will see all those aspects of cataract surgeries, like about their wound, about their reactions in the AC, their positionings in the positions of IOL, and after their feedback, they have to create a logbook also. Along with this, I am ending my talk. So if some persons or candidates are interested in our program, they can mail us in this email address, and we will actually forward this mail to the HR section, and they will allot the slot for the training. Thank you.
Sumanto, I would like to request you to say how much exposure our trainees are getting nowadays, the number of surgeries when they are trained.
So I will not be very embarrassed about the number of surgeries, but I would say that the trainee who has been trained in our institute, they will be quite confident in doing SICS and FECO. If we talk about the regular or the least number of surgeries that they used to get, for the 4 weeks program in short-term training, they used to get around 30 to 35 cases, and some candidates who were really very competent enough and who have done many cases in their previous institute, and few of them has also done around 50 to 60 cases also. And for the long-term 80 months program, they used to get around 1200 to 1500 cases, and including that will include around 300 of FECOs, and last 1 month we used to give also FECO with foldable lenses also.
Then
sir, like if somebody from Kerala wants to come and do a training there, see, you mentioned the fees is excluding the living expenses, but do they get a accommodation, like they pay for it and get an accommodation in your premises?
Yeah. We have a bachelor dormitory in our premises. They used to give a single room with attached bathroom. There will be a community kitchen also.
Yeah.
Actually, there is no other place to stay here.
Yeah, that. I understand. That's why I specifically asked, and so this is what those who are watching would want to know. So I just asked.
Yeah, and they have to be mentally very much prepared that they have to spend the entire time in village. And so far we didn't have any issue. And we had, through reference, we had candidates from Moorfields Eye Hospital. Even we have trained surgeon from Wills Eye Institute. And even we had candidates from Latin America. We didn't have any issue regarding accommodation and stay.
No, sir. That people are coming up focused and want
to learn something. That's the thing.
They won't be bothered about nightlife or whatever.
So I would like to request Dr. Subra to highlight the other issues of training.
So thank you, Dr. Asim for giving me the opportunity. One more thing that we emphasize is our trainees, before they leave us, that is, before they leave the organization, they should learn how to manage their own complications. So whenever they have a complication, we seniors go and manage it. But last 6 months, we try to see that they are capable enough to handle their own complications. At least I am very meticulous about this, and I try to teach them scleral fixated IOLs. Because without learning how to fix your own problem, who is going to come and help you when you are doing independently in a private setup or anywhere else. So last 6 months, it is very important that you handle your own complications. So we teach them how to do a good vitrectomy, how to place a 3-piece IOL in whatever remnant part of the PC that is remaining, how to place a CTR, all the difficult cases. And last 2 months, I make it very, I see to it that they do it independently. So sometimes I even walk out of the OT. This was taught to me by Dr. Nachiar, that in the when you can do a case independently without having your consultants around, that is the time you know how to fix your own problems. So this is one thing I would like to add, that in our institution, we make it clear that they learn scleral fixated IOLs before they leave our organization and start practicing elsewhere. And other things have been very nicely covered by Dr. Shumanta and Dr. Sil and the other participants also. So this was only little small thing that I really wanted to add. To make them confident, you have to learn to manage your own complications. This part we don't really pay importance. We just feel we will just put an IOL, do an phaco. What happens if you land up with a PCR or with a zonular dialysis? So you have to handle these independently.
Thank you. If you have any question from any of the participants.
Can we come out again, like, so how many short-term 4-week fellowship training persons do you take? Let's consider 6-month period. So would there be 2 people at the same time going for the same program?
No, we are very particular about the number of trainees at a time. We don't want to handle too many surgeons at a time, because then we can't do justice to them. So we invite applications and we look at the slot available and then we invite them. But our waiting time is not that long. So Manto, how much is the waiting time? Usually by 2-3 months they get the slot.
Yeah, obviously. So for each institute, we will have only single slot at any time. So only one candidate completes his or her training, then only the second candidate will get the slot.
Okay. Thank you, sir. Like, basically, this is what I wanted to be conveyed. Like, the expenses, where to live, all those, and you are confident that those people who are trained from there are going to be confident, and I feel this is a wonderful place where those who want to learn surgeries should prefer. So if no one else has any other queries, other institutions, anyone, we will go to the. Thank you, sir. Thanks a lot.
Thank you for
staying with us. Yeah, Dr. Girija, Elizabeth, ma'am.
Hello, Sreeni.
Yeah, one second.
Yeah, Dr. Sreeni, I am here. Am I audible?
Yeah, ma'am. One second. Okay, I mean, just had this thing. Okay, you can start,
ma'am. Good evening to everyone. I think I should congratulate the KSOS and Dr. Sreeni in particular to arrange such a program. People are looking, the freshly passed out students are looking for training in different institutes, and such a program will be helpful to all the juniors. The Little Flower Institute of
Ophthalmology. Ma'am, can you make it full screen, ma'am?
Yeah.
Yeah. Yes, ma'am.
Yeah, the Little Flower Institute of Ophthalmology is working in the field of ophthalmology for more than 50 years now in Kerala. And from the very beginning, the training and education was an important part of our work. And the DNB program was started in the 1980s in this institute. Fellowship program was also started very many years ago. And this is the photograph of Little Flower Hospital. I'll just show our statistics, but since we are in Kerala, there are so many eye hospitals in and around. The number of cases we do may not be as great as the big institutes like Aravind or something like that. 2022 was just after COVID. So we catered to 174,000 people as an outpatient. And of that, of the total outpatient, 8.9% and nearly 9% was the free patients. And coming to surgeries, cataract surgery, we maintain a ratio of 60-40. 60% of the cataract surgeries are paying, 40% are free. We conduct routine eye screening camps. Last 1 year, we had about 137 camps where we screened about 28,000 people, and we picked up more than 3,000 patients for cataract surgery. And this is the bar diagram showing the free patients and the paying patients. This is the free surgeries of free SICS surgery, and this is the paying SICS. Whereas when you compare in the phaco, this is the paying phaco surgery and the free. So phaco surgery, the free patients are less, whereas in SICS, we do more of free surgeries. So this is mainly meant for training purpose. Coming to training, see, we have full-fledged facility. This is one of our OT showing microscope with the observer eyepiece and recording system. We have got camera and recording system in all the OTs. We have 8 such OTs, and we have got wet lab facility. And before a junior person starts on a real patient, we give wet lab facility. This is the video of one of our DNB students doing surgery on a god's eye. First, we give animal eye. These DNB students are asked to record their cases and show the consultant. Now you can see the tunnel being made by one DNB student, and only when we are satisfied with the type of surgery, then only the wet lab, then only we allow real patients. After doing a god's eye, we give human eye, which is discarded from the eye bank. This is one of our doctors practicing on a human eye. The juniors are insisted to record their cases, and one consultant will be around to watch them. And once they make a perfect tunnel and perfect capsulorhexis, then only they are given real patients. And the real patients will also be given under supervision and stepwise manner. The juniors are asked to observe surgeries done by consultants before starting on real patients. They have to maintain record, and after that, presentations are to be done, and which are evaluated and corrections are given by the faculty. Coming to our training programs, we have got DNB 6 seats every year, and then we have fellowship programs also. We have long-term fellowship programs of 2 years duration in all specialties and comprehensive ophthalmology. A comprehensive ophthalmology fellow will be working in all units like pediatric ophthalmology, retina, all the units, and then they will be given cataract training, both SICS and phaco. And then long-term fellows in pediatric ophthalmology, strabismus, glaucoma, oculoplasty, orbit neuroophthalmology, medical retina, surgical retina, and cornea are available. In this, apart from the retina fellowships, that's the medical retina and surgical retina, people don't do the cataract surgery. All the others, like a fellow in pediatric ophthalmology, fellow in glaucoma, fellow in oculoplasty, and cornea fellow, they are all asked to do SICS and FACO. We have got short-term fellowships in SICS lasting for 3 months. We used to take people for FACO fellowships, but at the moment we are not taking anyone for FACO fellowship, short-term fellowship. Long-term fellowship is available. Short-term fellowship, FACO is not given right now because the number of complications are too much to deal with. You know, the Kerala, the literacy rate is very high. The patient expectation is very high, and so we cannot afford to make any complications. So at the moment, we don't have an exclusive short-term fellowship in FACO, whereas we have a short-term fellowship in SICS, and our all long-term fellowships are given chance to do FACO, and they will be perfected in SICS and FACO. And Dr. Sreeni was very specific to declare our stipend given for this long-term fellowship. The stipend given to long-term fellowship is similar to DNB program. That is around 50,000 rupees per month. That is at par with the DNB, and they will be asked to pay a nominal fees. Whereas for short-term fellowship, we don't pay a stipend; they have to give a fees. All long-term fellows will be given cases from the very beginning of the fellowships, and SICS will be started from the very beginning, and FACO training will be given in the last 6 months of the program. As on an average, all long-term fellows on an average would have done more than 500 cataract surgeries SICS, and FACO not that much, maybe around 50 or so. But if the patient, if the fellow has got a good surgical hand and is ready to come at odd hours and work for long hours in the OT, they will be given more cases. Coming to the duties expected from these fellows, they have to attend routine outpatient, inpatient services, participate in all teaching programs, and they have to do stay duty as first and second on call, attend all outstation camps and hospital camps. They encouraged any paper presentation and publications. I think that's all what I have to say. I think Dr. Girija will take on from here. Thank you, Dr. Sreeni. Thank you, all the viewers.
Thank you, ma'am, as a comprehensive presentation on the training facilities available there. Ma'am, can you unshare, please, ma'am?
Yeah.
Dr. Girija.
So good evening, everyone. Thank you, Dr. Sreeni, for giving me this opportunity. So I'm asked to present the manual small incision cataract surgery as we do in our center. I'll be going through the various steps. As all of you know, these are the 3 cataract procedures that we practice: the extracapsular cataract extraction, the small incision, and the phaco. So now the small incision is a very popular technique, especially in the training centers and also high volume centers, because it has a less operating time, a shorter learning curve, and it's a procedure that doesn't require any special machinery. So it's a cheaper technique which can be done in any type of cataract and at any age. And it has a better wound stability, a shorter convalescence, and an early visual rehabilitation. So it's a perfect technique for CAM surgeries with less expensive and high turnover. So for a beginner, when you select a case for small incision cataract surgery, a thorough preoperative workup is a must. So always avoid taking extremes of age, that is very old and very young, and also patients with comorbidities who cannot lie down for a long time, because usually the beginners take a longer time than the consultants. and select the eye properly. The patient should have a prominent globe, a cornea, clear cornea with a healthy endothelium, normal depth AC, or AC should be deeper. Do not select a post-PI patient or a shallow AC. The pupil should be well dilated and the sonule should be intact, and the cataract should be of a softer variety. Always do a thorough preoperative workup before surgery. You have to work up the patient yourself. And on the day of the surgery, you have to block your patient, and because learning the anesthesia is also a part of learning. So it is better to block your patient because you will know the shortcomings then. And these are the various instruments that are used for a small incision cataract surgery. So I'll just go through the steps. So the first step is a bridle suture. So for a superior section, you need a superior rectus bridle suture, which will help you to fix the globe. And also it will provide a counter force during certain steps like nucleus expression and epinucleus expression, etc. So you have to use a superior rectus forceps, turn the globe downwards and grasp the conjunctiva tenons and the muscle and pass the suture underneath. So the bridle suture, usually a 3-0 suture is used, and you have to pull it tight and fix it with a forceps so that the globe, once the superior rectus bridle suture is fixed, it will be turned down and there is a better exposure of the surgical space. So you make a conjunctival flap, just do a peritomy, adequate size. Using a scissors, you have to dissect the conjunctiva from the underlying sclera. So as you cut the vessels, there will be some amount of bleeding. So you have to clean the area and use gentle and adequate cautery so that when you make the channel, there won't be any bleeding. If the adequate cautery is not done, it can result in a postoperative hyphema. The next step in what we follow is the next step is the side port. Some centers, they practice like the sclerocorneal tunnel is made, but in our center, we make a side port as the next step, because then after making the side port, you can inject visco and the globe becomes tight so that the sclerocorneal tunnel making is easier in a tight globe. So, and the location of the side port is also very important because through the side port, we do many steps of the small incision surgery. So just take the blade, enter up to the maximum width and come out. No extra movements. So once the side port is made, you can stain the capsule with the trypan blue. This is a must for a beginner because it helps in better visualization and also makes the capsulotomy or the capsular access easier. And after washing with the DSS, you can inject viscoelastic so that remove all the air bubbles and it will tighten the globe. Put some visco over the cornea so that it help in better visualization, prevents drying of the cornea, and you'll get a slight magnification too when you're doing capsulotomy. And the capsulotomy needle is made from a 26 gauge needle, as all of you know. The tip is bent at 90 degrees and you bend it upwards near the hub of the needle. So you make a capsulotomy needle, and here because of the red reflex, the capsulotomy is very easy if there is a red reflex. So turn the globe so that you get the red reflex. You make a nick, make a flap and fold it over the anterior capsule and pull it towards the intended direction of the tear. And always see to it that you pull it inwards so that there is no rhexis run away. And the rhexis has to be done throughout, and always you have to leave and then recapture. So make the rhexis complete and then you have to inject visco so that the globe is tight. Then the next is the sclerocorneal tunnel. So as all of you know, the tunnel is a triplanar thing. So there is a vertical scleral part, a horizontal scleral part, and an angled entry into the cornea, into the anterior chamber, sorry. So unless and until you make the angled entry or the correct thickness of the scleral flap, you will not get the correct triplanar incision. So if the scleral flap is thick as it is shown here, then it will result in a premature entry. If the scleral flap is thinner, it can result in buttonholing and more of induced astigmatism. And two important things are the location or the placement of the initial groove. It has to be around 2 to 3 millimeters behind the limbus, and the length of the channel. Length of the channel is this the distance between the two ends of the groove, and it depends on the size of the cataract or the denseness of the cataract. So if it's a large nucleus, then you have to make a larger incision. If it's a soft cataract, then you don't have to be that big. But anyway, the minimum length is 6 millimeter. As you know, the PMMA lenses have a 6 mm optic. So you can make a 6 to 7 millimeter incision, and you can make a groove, and then using a crescent knife, you can make the scleral channel. So you grasp the conjunctiva, fix the globe, and make a straight line or a frown shaped incision. And then with the crescent blade, making wriggling and swiping movements, you have to make the tunnel. So the scleral tunnel, and while making the tunnel, always make sure that it is the correct depth. If it is the correct depth, you'll be able to just see the crescent blade. If it is too thick or if it is opaque, that means it's a thick flap. If it is too visible, then it means that it's a thin flap. So make the internal lip, and always make sure that the crescent blade is in the direction of the globe. That is, as you reach the dome of the cornea, you have to tilt it slightly upwards and depress the heel. And always be sure to make the side pockets so that you will not have any difficulty when you are trying to express the nucleus. So once you have made the tunnel, you have to make the entry into the anterior chamber using the keratome. So you can use either a 3.2 millimeter keratome or a 5.2 millimeter. So make an entry with the 3.2 and then extend it sideways using a 5.2 millimeter keratome. Always be sure that you cut when you enter. So, and it is the side pockets have to be, it has to reach the end of the tunnel. So both the ends have to be reached, and always verify it after making the tunnel. And while making this entry, you can see that the visco is expressed and the globe becomes slightly softer, which is a requirement for the next step, that is the hydrodissection. Because in hydrodissection, you are going to inject fluid between the capsule and the cortex. So if the globe is too tight, when you inject more of fluid, it can result in a rupture of the PC and a nucleus drop. So always see that the globe is slightly decompressed before injecting the fluid. So when you have to inject the saline or the BSS between the cortex and the capsule. So tend the capsule slightly. You can see that a fluid wave has passed underneath and the nucleus has been slightly lifted up. With each fluid wave, the nucleus rises. So generally tap on the other side so that the fluid doesn't accumulate under the nucleus and cause extra pressure on the PC. So once the nucleus has lifted up, sometimes one pole tips up. So then it becomes very easy to collapse the nucleus. So after the hydrodissection, this will separate the cortex and the nucleus from the capsule. So once the nucleus, one pole has come up, you can use a Sinski hook. You can hook the equatorial or the subequatorial region, and then you can slightly lift and rotate the nucleus so that the nucleus comes out into the anterior chamber. In the second video, in the right side video, you can see that it has already come out just by injecting a little amount of fluid, because it was an adequate size rhexis and a softer nucleus. It has come out, and using the cannula itself, I was able to rotate and take it out of the capsular bag, and the nucleus has come out. And once the nucleus is in the anterior chamber, you have to express it. There are various techniques for nucleus expression. What we use in our institute is visco expression and with the vectors. So I heard that PSR saying that he uses the FECO sandwich technique with 2 instruments. So these are the techniques that we follow in our institute because these are safer. In the hands of a beginner, this visco expression is the safer technique. You inject visco all around the nucleus and pass the cannula underneath the nucleus and keep on injecting visco and depress the posterior scleral lip so that along with the visco, the nucleus comes out, the least injurious to the corneal endothelium. So, but the section has to be of adequate length. Then there is the vectors expression. So this irrigating vectors is one thing that it is an instrument, it's an excellent instrument. It has 3 irrigating ports at the tip and has got a concave anterior surface. So you have to check the patency of the vectors before using it. And so you have injected visco, and now you are introducing the vectors underneath the nucleus. Always visualize properly so that no iris is caught. Now you slowly pull it backwards and engage it in the wound and then inject the fluid. So along with the fluid, the nucleus comes out. Next is the cortex aspiration. So as you know, the nucleus is expressed, so the cortex has to be washed out so that there is no after cataract later. So you have to do a thorough washing with a Simcoe cannula. The Simcoe cannula is the same as that is used in the extracapsular. It has got an aspiration port at the on the top and a side port which irrigates. So you go under the cortex, you catch hold of it, you bring it to the center, and then you aspirate. You should not do aspiration under the iris. So beginners should be very wary of that, because you can catch hold of the anterior capsule and you can result in a zonular dialysis. So cortex aspiration has to be complete. You should not leave behind any cortex, because that can, yes, next day you will see a large lump of cortex in the center, and the patient may have to be taken for cortical wash again. So try to aspirate as much of the cortex as possible, loosen it by injecting fluid, then again try to aspirate it. Next step is the implantation of the IOL. So the IOL lens holding forceps is used. This is a rigid PMMA lens, a 6 mm optic. So you're holding the IOL and pass it through the channel, slightly tilt it downwards so that the leading haptic goes into the bag. Now keep it in the bag. Use a Sin's key to dial it. The optic and the haptic goes into the bag. So perfectly positioned IOL. Now after placing the IOL, you have to wash the viscoelastic that has been there in the anterior chamber, and also wash the visco from behind the IOL. That's very important. You have to wash it from behind the IOL, because no amount of visco should be left in the anterior chamber, because it can result in an inflammatory reaction later. And next is the wound closure. So once the IOL is placed, you can hydrate the wound. So as the sclerocorneal wound is a self-sealing wound, once you hydrate and the glove becomes tight, the wound seals by itself. Now we can repose the conjunctiva over it. So conjunctiva is placed over so that the wound is covered. So you can see a stretch line here, which shows that the IOL is in the bag. Postoperative care is with antibiotic and steroid drops, and glass prescription can be given after 1 month. So the take-home message to the beginners or the postgraduates is that always do a thorough preoperative workup and do a proper selection of cases. Don't go for any difficult or complicated cases, and avoid doing that, and always learn the surgery stepwise. So we do it in our center. They are given stepwise, and also do it under proper guidance. And in case of any complications, never hesitate to seek assistance, because all of us are around. So any of the consultants will be very happy to help you. So even if the senior postgraduates, you have to, in case of problems, you can seek assistance. And always keep in mind that there is no shortcut to mastering surgery. Only practice makes it perfect. Thank you.
Thank you, Dr. Girija. It's a really wonderful teaching video. So we have covered most of everything that I wanted from this program. Dr. Girija, we can unshare the screen. So if anyone has anything, any doubts or anything, Dr. Dahlia.
Hello, sir.
Yeah.
Am I audible?
Yeah.
Sir, I was all the way traveling, so I could not hear all the thing, but when I reached to my, it was an excellent program which you have organized. It will be very useful for the postgraduates and fellows for planning their training and all. Very much thank you, sir, for organizing such a wonderful one.
It was this is the first time that I've sat through an entire program. So there were a lot of take-home messages for even the training institutes, what the other institutions are doing. It was really wonderful. I'm happy that somehow I thought about it, and we'll continue the same process tomorrow. We'll have another 7 institutions joining, and tomorrow from 5:30. So we'll wind up the program for today. Dr. Hossan Zaida from Egypt was supposed to join and show some surgical videos. He's not reachable. He was in Ghana for this thing. So we will wind up the program and continue with the program tomorrow. Thank you. Good night, everyone.
Thank you.
Thank you. Good night, sir.
Good night. Good night. Thank you.
Thank you, Srini. Good night.
Thank you.